Dr. Fatma Al-Abri. Dr. Fatma Al-Abri, she is a senior consultant, maternal fetal, and she was the ex-director of Gyne department at Ovary Hospital. She did her undergraduate study and received MD from Sultan Qaboos University. And she did her postgraduate subspecialty training in maternal fetal at Saudi Arabia. And she is also a member in many hospital and national committees, and she was also participated in several national and international courses. So Dr. Fatma, she will moderate today's session. Dr. Fatma, the microphone is yours. Thank you.
Assalamu alaikum. Thank you, Dr. Moza. Thank you, the organizer committee, for this very nice course that they organized and really needful for Oman as the basic course needed for all the obstetric and OB-GYN group. And today, the last day of this course, and it was planned for Gyne, but Dr. Moza still, she wants obstetric to be involved in that. So we will start with her to complete the picture of obstetric with the cervical assessment. And Dr. Moza, all of you, well known to all of you, she's senior consultant and she is fetal medicine specialist. Welcome, Dr. Moza.
Thank you, Fatma. Thank you. I think somebody is still sharing their slide. If you stop sharing your slides so that I can present my slides. I think Mariam?
No, actually, Doctor, it's your slide.
Wallahi?
Yes.
Sorry. Okay. Okay, so my presentation actually will be short one, and it is about cervical assessment. We all know that preterm labor is one of the major leading causes for neonatal morbidity and mortality worldwide. And it has been shown by several studies that cervical measurement is a good screening tool for identifying those patients who are at risk of preterm labor, as well as it has been also shown as a good tool in guiding the physician regarding the management of those patients who are presenting with threatened preterm labor, whether extreme preterm labor or early onset preterm labor during pregnancy. So in my talk, I will try to cover these learning objectives. So at the end of this lecture, you will be able to visualize and measure the cervix in pregnant patient with vaginal sonography. You will be also able to identify and manage patients with short cervix, and also to manage patients with threatened preterm labor. The key questions that we will try to answer them are: what is the correct technique for assessing cervical length using transvaginal imaging? And when in pregnancy are cervical length measurements useful? So we all know that cervical assessment ideally should be done by transvaginal scan. But cervix also can be visualized transabdominally. The issue with transabdominal that the transcervical canal and the tracing of transcervical canal is poorly traced with transabdominal scan. And that is because of many causes. One of them, of course, is the shadowing of the fetal part, as in this image, that may obscure the visualization of the transcervical canal, as well as also the shadowing from the placenta. In addition, the bladder overfilling may also cause issue with the identification of the transcervical canal. No, I did not move it. So the best and the ideal way of assessing the cervix is by using the transvaginal probe. And that is because with transvaginal probe, you can visualize the cervix and the endocervical canal clearly by identifying the anterior and posterior lip of the cervix. Before doing the transvaginal scan, it is very important to take verbal or written consent from the patient to explain fully the procedure to her. And when you use the transvaginal probe, it is very important to clean the probe and to cover the probe with sterile cover probe using lubricants also, and to place the probe in the anterior fornix with gentle introduction of the probe. And after that, on the image, you can easily identify the internal as well as the external os. So what is the difference and how it looks, the normal cervix from short cervix on the image? So usually the normal cervix or the cervix with normal length, it has a curvature appearance, and the short cervix, it has straight appearance for the cervical canal. And short cervix can be associated with funneling, but it can be also without funneling. So it is not important any short cervix to have funneling. It can be short cervix without funneling. Full bladder can give you a false or increase the length of the cervix if it is overfilled or even if it is full. So this is very important to ask the patient before doing the transvaginal scan to empty her bladder, so that the overfilling of the bladder doesn't increase the cervical length or obscure or mask if there is any cervical funneling. The previous image actually showed you the importance of emptying the bladder. This is the same patient. This is when her bladder is full, and this is when the patient emptied her bladder. You can see that with full bladder, the cervix have been shown to be normal length. But after she actually emptied her bladder, you can see that the cervix actually is short, and it was falsely measured as normal cervical length because of the full bladder that compresses the cervix and give you impression that the cervix is normal. These are studies which has been done to identify the normal cervical length in a patient between 16 and 36 weeks. The one on the left, it was done by Solomon, and it was published in 2019 in the ISUOG journal. And what they did, they looked to the normal cervical length in 6,614 pregnant patients between 16 and 36 weeks. And they used the Z-score distribution to produce this normogram for the cervical length according to the gestational age. This study, which was done looking after cervical length at 23 weeks in 2,567, they did it to identify which patients are at risk of premature labor. And they found that those patients with cervical length below 15 millimeter, the risk of preterm increased exponentially. And those who have actually cervical length more than 25 millimeter, the risk is very low, below 0.5, compared with 70% when the cervical length is between 5 to 10 millimeter. So what is the protocol for cervical assessment? I already said, and I mentioned in previous slide, that it is very important before starting the or the cervical length assessment is to ask the patient to empty her bladder after explaining to her fully the reason from doing transvaginal scan and what is the indication for doing such study. And after that, and after emptying her bladder, the patient will be positioned in Gyne position. Vaginal probe using vaginal probe of 5 megahertz and above. After covering it with a sterile cover probe, should be introduced gently in the anterior vaginal fornix. And it should be introduced to get the sagittal view of the cervix. The image on the screen should be magnified to occupy more than 75% of the screen. And of course, after identifying the image of the sagittal view of the cervix, it's very important to visualize the external os, the internal os, and to trace the endocervical canal between both osses. And of course, you should be aware about the difference between the isthmus or the segmental thickening that can happen with uterine contraction. So avoid to include that segmental contraction within the cervical measurement. And of course, avoid applying excessive pressure on the cervix. The cervix is very soft. So applying pressure may either give you false reading or may also obscure or mask if there is any cervical funneling. And take your time, at least you have to take 3 measurements and use the short measurement to be reported for the cervical length. This is 2 images, and this is just to talk about the importance of identifying the isthmic or the segmental thickening of the lower uterine part, and how it can misguide you and include it in the cervical measurement. If you trace here the cervix, this is the external os. External os can be identified by identifying the anterior and posterior lip. And then you should trace the cervical canal by looking to the cervical mucosa. And the issue or the difficulty is with identification of the internal os. External os easily can be identified, but the issue with identification of the internal os. It is very important not to include the lower part of the uterus, and especially that happen when there is uterine contraction. It may give you false impression that the cervical canal actually extending till this, and this is the internal os. This is not the internal os. The internal os is here. So this is falsely have been measured and reported as 6.7, which is wrong. After the cervical or after the uterine contraction disappear, you can see nicely that this is the cervical length and this is the endocervical canal, which is 3.7 and not 6.7, because the uterine contraction has falsely give you that impression of the endocervical canal. So what is important to avoid including the lower uterine segment or the isthmic part of the uterus is to visualize or to trace the endocervical canal by which usually on the image look like homogeneous throughout the cervix. It's very easy, as I said, to identify the external os, but the difficulty in the internal os. So very important not to include the segment part. So that is actually the endocervical canal or transcervical canal. And with both, you can have the same reading. So now we talk about segmental contractions and how segmental contraction can affect cervical length measurement and what is you have to do to avoid such false reading by identifying the external os and the internal os, and in between them you can trace the endocervical canal. The other pitfall that can happen is when there is myometrial or uterine contraction, they may also give you also a false impression that this is a funneling. This is actually not a funneling. This is a false pitfall due to myometrial contraction. And you can see how this image with poor quality, you cannot actually trace the endocervical canal, and you cannot identify where the internal os and where is the external os. This is a patient which have been referred to the A&E because they were suspecting that this patient has cervical funneling with short cervix. And after repeating the scan in the A&E, you can nicely see that this is a normal cervix, yeah, with no funneling. So it was false impression due to myometrial contraction that give you the impression that this is a cervix with funneling. Actually, it is normal cervical length with no funneling. This is just a video showing the importance of not putting a pressure on the cervix. What you need is to put gently the cervix in the anterior fornix, apply little pressure to identify the external and internal os, and then completely remove the pressure on the cervix. You can see here after removing the pressure from the cervix completely, there was funneling which was masked by the pressure, as well as the cervix is not long, it is a short cervix. So it is very important not to put a pressure on the cervix. And when you introduce the probe, introduce it very gently and relieve the pressure completely over the cervix. So this is the proper technique. After introduction of the vaginal probe, exert some pressure to identify the cervix and cervical canal, and then relieve or release completely the pressure to measure the cervical length. Because putting a pressure, as I mentioned, it may mask or obscure if there is any cervical length, or it may also falsely increase the length of the cervix. Yeah, especially if there is short cervix. This is a study which was done by the Fetal Medicine Foundation, looking to the prediction rate of using cervical length alone or prior risk of preterm based on maternal or obstetric history alone to identify those patients at risk or at high risk for preterm labor. And they found that combining both cervical length with prior risk of preterm based on maternal and previous obstetric history, the detection rate actually has increased to 80% for extreme preterm and to 60% for early preterm birth, instead of using cervical length alone. This is a meta-analysis also, which was done by Romero, and this is one of the first meta-analyses which were published in the 2012 in the American Journal of Gyne. And they looked into 4 studies, including 775 women. And they found that actually using vaginal progesterone in women, especially in women with previous 1 preterm delivery, and asymptomatic, presenting with short cervix in the mid-trimester, they found that using vaginal progesterone has reduced the risk significantly from 22 to 12.4 for 0.58 relative risk. So now we have a good and excellent screening tool, which is cervical length measurement, and we have also a good intervention that may reduce the risk of preterm in those who have been identified by cervical assessment as short cervix in the mid-trimester. to reduce their risk of preterm labor. Now we will talk about the use of cervical length not only in the screening but also in the management of those patients or symptomatic patients who are presenting with threatened preterm labor between 24 and 36 weeks. This study, which was done by Tsoi et al. And published in 2013 in the ISUOG journal, they studied 216 women between 24 and 36 weeks, and they presented with threatened preterm labor. And they found that when the cervical length below 15 millimeter, the rate of preterm delivery within 7 days has increased dramatically. So if the cervix is more than 15 millimeter, the risk is very low. If the cervix length is below 15 millimeter, the risk of going or deliver within 7 days is high. And in such patients, it is very important, this way of using cervical length can help you to triage patient and to identify which patient they need to be on tocolysis and which patient they need to receive steroids. We all know that we are giving unnecessary steroids and unnecessary tocolysis for every patient presenting with threatened preterm labor, although majority of them, they are not going into preterm labor. So such intervention can be more cost effective by using cervical length to triage which group should receive steroid and tocolysis and which group actually no need for intervention. And this is what it was shown in this study, which was a randomized control trial, where they look and divide the patient who are presenting with threatened preterm labor into control group and into a group where they did cervical length measurement. And those whom they didn't use cervical length to triage patient, you can see that 90% and 100% they receive unnecessary steroid and tocolysis. And the number actually has reduced dramatically to 14% with the use of cervical length to triage patient and 33% also for tocolysis. And this is another study actually showing how using short cervix alone can help you in predicting which patient going into delivery within 48 hours of presentation. So even if you don't have fibronectin test in your unit, short cervix alone actually is doing very well in identifying those patients who are at risk of going into preterm labor. You can see that 42% the protection compared with 27 with fibronectin, and with with absence of fetal breathing, which is 54%. Traditionally, fibronectin test has been used to also screen for those patients who are at higher risk of going into preterm labor. And in some units, they use it when they want to triage patient and to guide them regarding the management, whether to give them steroid or tocolysis. So first of all, you have to do cervical length. If the cervix is less than 15 millimeter, then they are at high risk of going into preterm labor. And then, of course, you need to give them steroid and put them on tocolysis. If the cervical length is more than 30 millimeter, then they are very low risk to go into preterm labor, so no need for any intervention. But if the cervical length is between 15 and 30 millimeter, if you have fibronectin test in your unit, you can do fibronectin test. And if fibronectin test is positive, then they are at high risk of going into preterm labor, and you have to give them steroid and tocolysis. But if the fibronectin test is negative, then they are at low risk of going into preterm labor and no need to give them steroid or tocolysis. But even if you don't have fibronectin test, cervical length alone, as it was shown in the previous study, is actually doing a great and has good detection rate in helping you to triage the patient. So at the end, these are the take-home message. The transvaginal approach should be used in preference to the transabdominal approach when examining the cervix with ultrasound. And we have said why it is transabdominal is not recommended. The correct technique should always be used to avoid any pitfalls or misdiagnosis or wrong interpretation of the cervical length. Care should be taken not to overestimate the cervical length, and we have also shown in previous slides how to what is the correct technique of measuring the cervix and what things can give you false reading regarding the cervical measurement. Excessive pressure, avoid to put excessive pressure with the probe because that also may mask if there is any funneling and also may falsely increase the cervical length. Thank you. I think the microphone is back to you, Fatma.
Thank you, Dr. Moser. Thank you that you keep on time. And the question will be answered by the end. Now we will move to the Gyne part, and we will start. There is a little change in the program because Dr. Dina will talk about the basic of ultrasound, Gyne ultrasound. And Dr. Dina Saleh Al-Belushi, she is graduate from Sultan Qaboos University, and she did specialization of obstetric and ultrasound, obstetric and gyne ultrasound in Cardiff University. She is working now as specialist in Sultan Qaboos University. She is also a national trainer of ultrasound. Welcome, Dr. Dina.
Thank you very much, Dr. Fatma. Everybody can hear my voice?
Yes.
So you can hear? All right. So we'll talk about the ISUOG basic training of gyne ultrasound examination. So at the end of this session, the learning objectives will be understand the systematic approach to perform abdominal and vaginal gyne ultrasound scans. And the key points here are how to do and perform the thorough systematic gyne ultrasound examination, and when should you perform the transvaginal versus a transabdominal ultrasound, what is the correct scanning technique image for assessing the vagina, cervix, uterus, and ovaries. And the key points here, understand when to perform the transvaginal versus the transabdominal examination. Understand the importance of probe orientation very well first, and then the step to approach a systematic gyne examination accurately, and assess the pelvis during the ultrasound examination. So it's always very good to refresh your mind with the anatomy. And we always go first anteriorly, and you can always see the pubic symphysis and go back to the urinary bladder. The uterus here is very clear, cervix and the vagina. Posteriorly, you can see the bowel and the rectum, and don't forget always the pouch of Douglas here. So always when you start the gyne examination, either abdominally or vaginally, you have to check the, keep in mind your anatomy. All right, so gyne examination technique always should be the same procedure, and you always need to start in the same systematic way, and never start your examination if the patient is coming with abdominal pain or she's coming with any bleeding, vaginal bleeding, and you suddenly see a very attractive cyst there, and you would go and directly start with that. And you, by the end of the examination, patient is out and you forgot to look at the endometrium, you forgot to look at the other ovary, you forgot to look at the cervix. Always try to familiarize yourself with all the organs in the gyne examination. Don't forget to start with the vagina, cervix, uterus, and then go to both ovaries. It's very important to see how the normal look of the cervix, what is the normal look of the myometrium. So look at those all very nicely, and then you can start your examination. So the first thing, so don't never forget to see those things in every examination you do. It's not going. Okay. So vaginal versus abdominal scan. When you start with the abdominal examination, or the probe that you are using is lower frequency. It ranges between 2 to 5. So with low frequency, you are having poor resolution, because low frequency means poor resolution. But in abdominal scan, you have got too much layers. You start with the skin, and then the soft tissues, the fats, then the muscles. All of these layers should be penetrated by the ultrasound beam to reach the organs at the end. So you need that much depth to reach the organs and to see the uterus. So that's why when you do abdominal examination, to penetrate those layers, you need low frequency to get that much depth. On the other hand, the resolution would be less, but you'll get that nice overview and you can see the full abdomen. And if there is any mass or a big fibroid or a big cyst, like 10 centimeter cyst, then you will be able to see it on transabdominally and you cannot see it vaginally. Of course, you would need a full bladder for the abdominal scan, because the bladder, full bladder, would push away the bowels and you can see your field very nicely. On the other hand, the vaginal examination, some people are using also rectal scanning for the virgins patients. And for those transvaginal scanning, you need a very high frequency probe. That's the endovaginal probe. And that ranges between 4 to 9 or 5 to 9 megahertz. And that's a superb resolution because the frequency is high. The higher the frequency, the higher the resolution. And you don't need that much low frequency in such an examination, because you've got a very small field, just one ovary, 2 ovaries and 1 uterus. So you don't need really that much depth to see. So that's why you will have a superb resolution with high frequency probe, but the poor overview. For example, when you are doing, you remember when you do the cervical length and you want to see, or the localization of the placenta on TVS, you cannot see the beneath that. You cannot see the fetus, of course, because you've got only limited depth for that. So you will see only the lower segment and the lower edge of the placenta, and then the cervical length, and that's it. Of course, you cannot see the abdomen at the same time. And you need an empty bladder, because a full bladder in transvaginal scan would push the organs away from your field and your ultrasound beam wouldn't detect it. So would you need a full bladder or always, or you would need sometimes no need to fill the bladder for abdominal examination? Well, that depends. If you are doing the examination as a primary scan and you cannot do a TVS for that patient, such as a single patient or virgin or whatever, then you need a full bladder. Ask the patient to fill her bladder, to drink water, and so on. But if you can do a supplementary scan as a transvaginal scan, and this is a supplementary examination, then you wouldn't really ask the patient to waste her time or waste your time and fill the bladder and again do the TVS. No need for that. You just do whatever you can see on abdominal examination. and then go directly to your transvaginal, because that is a superb examination, unless there is a big, for example, lesion that you cannot see on transvaginal, you have to see it abdominally. Now let's start our abdominal examination. So first of all, always and always start to orientate yourself with your probe. Hold your abdominal probe and get the probe and see where is your right, where is the left, where is the caudalocephalic in your image. So first, let's start where is the right and where is the left. So when you hold your probe, I will show you the next image. You hold your probe sagittally. You can see and touch this part and see which part is moving. And you can see that this part is moving here down, here where you are putting your probe. And this are the soft tissues, the skin, the fat, and then you will reach the bladder. So here is when you are touching, this part will be seen, and this is the right side of the patient. So this dot shows the right side of the patient, which is the left side of the screen. So there is an international agreement in transabdominal scanning saying that the right side of the patient is the left side of the screen, and it's the same with this dot. And this dot is seen in your screen, actually. You can see T for Toshiba machine, P for Philips, and M for Mindray. GE has got its own sign with GE. So you can see this dot there, and make sure your machine is putting it in the right place. And with the knobology revision, you can see there is something written right and left. And if it is left, change it to the right so that you will be in the right direction. So this is the right, this is the left. This is the caudal, and this is cephalic. See, this is the uterus. This is the endometrium, and you can see this is the cervix, and this is the vagina. So this is the caudal, see the vagina. So this is the caudal, and this is cephalic part of the patient. The caudal part where you are seeing the vagina, caudal part of the patient. Start your examination first sagittally. We always start to see the sagittal section of the uterus. So this is the sagittal plane. This is how you hold your probe, and make sure you are correct. Don't see the dot in the probe. It's not always leading you. This dot is leading you, and where you are touching that part. And then start your examination first. You move on sagittal scan right to left. So you will start seeing this is the fundus, this is the endometrium, and should be a continuous line up to the lower segment and cervical canal. And then you'll carry on with the vagina. You'll start here until you see the mid-sagittal view where you are going to measure the endometrium, and you will carry on to see the full uterus and sagittal right to left. Rotate your probe 90 degrees toward yourself, and then you can see the cross-section of the uterus. Rotate it anti-clockwise toward yourself. This is how you do it. Look at this, and you make sure that your dot is here and the same as this dot here, right side of the patient. So you are in the same direction. You will move your probe up and down in transverse section so that you can assess the uterus. You will get, this is the uterus and this is the endometrium. Again, this is the right side of the patient. This is the left side of the patient. Anterior, posterior. The same there. Anterior, posterior, caudal, cephalic, right and left. Then how to examine on transverse section. You will move your probe from down in the cervix. This is the cervix to the up of the fundus. Full examination and thorough examination of the uterus. You don't miss any hair fibroid at the end of the fundus. So just make sure that you're examining the fundus until it disappears. We're done with the uterine examination abdominally. And we will move now to transvaginal examination of the uterus, and then we'll go at the end to the ovary. So this is your ultrasound transvaginal probe, which is a high frequency probe that you don't need really that much depth. And you can see your field ultrasound beam here. Where is it going? You see, this is the uterus. It is touching the endovaginal. This is the footprint of the endovaginal probe. It's touching the cervix, and that's why the first thing you see if you are introducing your probe nicely, you will see the cervix. So see, this is the cervix, anterior in the urinary bladder, and this is the uterus, and it is entered into the vagina. So there, the uterus is not uniform, and you can see how does it look like here in transvaginal scan. And as we said, this is the right side. So this is the uterus, this is the cervix, this is the endometrium, this is the fundus, and here is the cross section of the uterus. You can see this is the footprint where you are introducing the probe, this one, and it is up here, and this is the right side of the patient, as we have agreed. There is no international agreement saying that the footprint should always be up in the transvaginal scan, not like the transabdominal scan. Though there are old school that who are using this because they feel that the anatomy in real life is like this, it's upside down. So they like to do this, but don't forget the patient right is always here. So it's fine to do it in this way. Just make sure that your orientation is correct. So now let's see our movement of the probe. This is the transvaginal probe. This is the anterior part. This is the posterior part. And your dot is here. This dot is the same as this dot, okay? And when you rotate 90 degrees to cross section, it will be the right side. So this is anterior. And this is posterior, and this is the way you are introducing your probe. This should be down and this should be up. And when you are in sagittal plane, you will move your probe right to left. This is sagittal plane, right to left. If you move up and down, you're only swinging the image. So you are not going to be able to assess anything by moving up and down in sagittal plane. You can centralize your image though. In transverse, you'll move your probe rotated. This is the rotation. So from the sagittal plane, you will rotate 90 degrees to transverse plane. This is the rotation. You rotate it toward yourself, means anti-clockwise. And that's why I always emphasize that it's better to put your thumb here where the dot is, like this, so that you can know that this is your anterior part and this is the right side with the transverse plane. On transverse plane, rotating 90 degrees toward yourself, anti-clockwise, you assess the uterus or whatever in up and down. You slide up and down. I hope it's clear for you. And then when we start our examination, you can see here, first thing that you see when you introduce your probe is the vagina. And that's before you touch the footprint into the cervix. So this is the vagina. This is how does it look like. And that's when you start just introducing the probe. You can see the bladder first and the rectum here is behind. This is your dot and this is the right side. So we can check this on this video. Realize carefully when you introduce your probe, first you see this is the vagina. Look at this. This is the vagina here, very small urinary bladder because it's emptied. And here is the rectum, the bowel. You see it's echogenic. Let's start the video and see it. We always introduce first and you can see the vagina. And then once you introduce the probe, you will see here. You will see the cervix here and then the uterus, and the cervix is the one that will lead you into the examination. Look at the video again. This is the vagina, and then cervix, the uterus, and then once you introduce the probe, you can see the cervix. And this is our cervix, and this is how it looks like. You can see that this is anterior and posterior lip. This is the cervical canal. From here, the internal os into the external os where the anterior and posterior lip meet. And you can see some common finding here, like this Nabuthean follicle or Nabuthean cyst. And from this cervix, you can see the meeting of the cervical canal into the endometrium, and this will lead you. So once you see the cervix and where it is leading you into the joining of the canal into the endometrium, you always put your probe down and you can see the cervix well. That is why I always emphasize that you need to put the patient first in a very good position so that you can move your probe freely. You can put a pillow, a big pillow below the patient's butt, or you can put her in a lithotomy position, or also you can put her by the end of the bed, put the foot on a chair, and then you can see the external genitalia very nicely. Introduce your probe and you can put the probe and move it freely up and down. That's the best position where you can freely move your probe. Believe me, if you put the patient only on bed without these positions, you will miss a diagnosis because you cannot put your probe down and see up. And you can see that when we are examining the ovary, because you need to go to the fundus, and this is the same, your cervix. So once you get the cervix, as we said, this is your footprint, and this is your cervix, anterior posterior lip, external os, and into the internal os, and you can see this is the joining into the endometrium, and the endometrium is full and nice, and this is how you can measure your endometrial thickness. This is the dot where it's gonna be. Here is your urinary bladder. And what are these echogenicities here? These are the bowels. Anterior, posterior. Get familiar to look at the myometrium so that if you saw any abnormal findings, you can see it. Arcuate vessels here, you can put the color Doppler, you can see it. Get familiar to every single part, every single anatomy so that you can see it very nicely and examine it nicely. And here, see, this is the rectum and bladder as what we have described. How to measure the endometrial thickness. You will take this very nice image and you will always examine the endometrium in the fundal region. Don't take it to the lower segment, or even if you saw more thickness here, because that's going to be a lesion. This is where you are going to measure it. And you measure it the widest, outer to outer, perpendicular to the midline of the endometrium, parallel to the fundus, and that's what the maximum diameter. Always measure it on in sagittal section, never in transverse section. And that is because the transverse section could be oblique. And if it is oblique, you cannot get the actual measurements of the endometrium. Now, this is the measurement of the total length of the uterus. And when you are measuring that, because you know that the uterus is not uniform, so you need 2 or 3 measurements sometimes and calculate them together to get the full total length. And this is on sagittal, always on sagittal. Anything in ultrasound, you need to get 2 measurements. One is the total length and the other one is perpendicular to this. It has to be perpendicular as much as possible. And then this is the anterior, posterior, total length. And then on transverse section, there is always 1 measurement, right to left, regardless how it looks like. It's always right and left. You can see here, very clear, and then anterior, posterior. And then this is the transverse, and you will take it right to left and never measure endometrium here. So you see the endometrium, but never measure it here. Now, how about the position of the uterus? What do we call it? So, you know, the anteverted uterus. This is anti means anterior or frontal. The verted means tilted. So the fundus of the uterus is tilted toward the anterior part to the urinary bladder. So this is anteverted uterus. Retroverted uterus, retro means backward, verted means tilted. So the fundus is tilted backward toward the back of the patient. So this is the fundus, it's tilted back to the rectum, it's not toward the bladder. We have got another thing called the antiflexed uterus. The antiflexed uterus is this one, and it is meaning that there is a kink in the body of the uterus, which is to the front. So this is a kinking to the front. So this is anti-flexed. Flexed means kinking of the body of the uterus to the anterior part. So anti-flexed uterus. And retroflexed.
5 minutes.
Okay.
5 minutes.
I'll try to be faster. So retroflexed means it is a kink towards the backward of the back. You can see here that this is the anteverted uterus. This is here is the bladder and the fundus toward the anterior part. This is retroflexed uterus, and this is here is the urinary bladder, and this is the fundus. So the fundus is away from the urinary bladder, retroverted. This is anti-flexed uterus, and it's very difficult even to measure it. So this is the kink of the uterus toward the anterior part where the bladder is. This retroflexed uterus, you see the kinking is here toward the opposite part, and here is the urinary bladder, and so it is retroflexed. And you can see here how we are doing the examination of the ultrasound transvaginal examination. Always start to introduce your probe and then maximize the image to reduce the depth so that you can get the higher size up to 75% of the image. Then examine the uterus right and left on sagittal section until you see and then you will see the so you will adjust the depth until 75%, and you can see here until you get the full length of the endometrium where it is continuous with the cervical canal, and you can get the anterior posterior diameter of the endometrium. You can see it is 1.5 millimeter, which is correlated to postmenopausal women mostly. And then you go and measure the full length of the uterus, and then perpendicular to that, the anterior posterior. This is the full length, then anterior posterior. And after that, you will go to do the transverse, rotate your probe 90 degrees, examine up and down, and then get the maximum diameter of the fundus right to left. Okay. And you have always to annotate uterus and transverse section. Then we will go to the ovaries. Don't worry, just a few slides are left. So with the ovary, we always start with longitudinal or whatever sagittal section or transverse. This is the total length. You are always getting the widest length in sagittal, and then perpendicular to that is going to be anterior posterior measurement, and then the transverse section of the uterus get right to left. And here what you are going to do is, regardless the shape of the ovary, you will measure right to left. And this is how you assess the ovary. We go to the transverse section of the uterus in the fundal part. This is a very important notice. Go to the fundus, find where is the corneal region and follow this corneal region. You see here, fundus, very nice. Go to the corneal region, follow that where the tubes are until you see the ovary. If you couldn't see the ovary, at least in sagittal section, you get me this image. This image is the adnexa, where you can see the iliac vessels. You can put the color Doppler to make sure that this is the iliac vessel. So iliac vessel, adnexa, here the fundus of the uterus. Search for the ovary here. It could be somewhere, slide up and down or right and left until you can see it. You are in transverse, slide up and down, you can see the ovary, and then you might see it here, here, here. So you catch it up and you can then optimize your image, make it bigger, centralize it and measure it. You will take 2 measurements in sagittal section and you will get 1 measurement on transverse section. Regardless your plane, you have to take the ovary, how it looks like. This looks like sagittal, so you will take 2 measurements. This looks like the trans. Take dual images and measures. After you finish 1 ovary, go back now to the transverse section of the fundus and trace the other part, which is the left side. Okay. Always regarding the tubes, you cannot see the tubes, but if there is a fluid in pouch of Douglas, you can see the fimbria here moving. Move. Transvaginal ultrasound is dynamic, so just move the probe and you can see here the fimbria. See? But this is normal. It's just because there is a fluid in pouch of Douglas, you can see it. As we said, the transvaginal examination is dynamic and interactive. So check the mobility of the organs if they are fixed or there are adhesions. And if there is any specific tenderness in a specific organ, which specific site like ectopic or torsion, you would know as well. And very important to know that normally the anatomy of the woman differs before and after the menopause, as we saw that the endometrial was very thin in that patient, and it changes in menstrual cycle, proliferative, secretory phase, menstrual phase, and always the key points. Always orientate yourself with the images. Optimize your images to the maximum and use the systematic approach. Systematic approach is your leading to transvaginal. It's everything, of course, but in transvaginal examination, this is your lead. Then from here, you can practice, read books, articles, and attend the advanced ultrasound courses. And don't forget, look at each single organ when you are examining. Systematic approach. And there are standardized terminology to describe different types of abnormalities. The International Ovarian Tumor Analysis, IOTA, the IDEA for the endometriosis, IETA for the tumor, endometrial tumors, and go to the ISUOG website. You will find lots of papers, lots of videos, lots of abnormalities where you can revise. Thank you very much for your listening. I hope I didn't take more time.
Thank you, Dr. Dina. Thank you for being in time. And now we will move to Dr. Maryam Shukri with the overview of the uterus. After Dr. Maryam Shukri, we'll take 15 minutes for praying time. So, Dr. Maryam, all of you knowing Dr. Maryam, but also some introduction about her. Dr. Maryam Shukri is senior consultant and she is endoscopic surgeon in obstetric and gyne department at SQU, Sultan Qaboos University Hospital. She is graduated from Sultan Qaboos University. She completed her residency program in gyne and fellowship in minimal invasive gynecological surgery at the University of Manitoba, Canada in 2010, and she is fellow of Royal College of Physicians and Surgeons of Canada, Besides the different clinical, administrative, technical, and academic responsibility at SQU, she is also part of national member. She is founding and current member of Oman Society of Obstetric and Gyne. She is the leader of the management team of Oman Fertility and Endoscopy Surgery Group under the ISUOG since 2018. And Dr. Mariam always, she had great effort to disseminate the knowledge and practice and safe endoscopic surgery throughout different activity, including workshop, conference, visiting surgeon, trips, supporting the initiation of endoscopic surgery in the country. Also, she is proficiency in gyne ultrasound as it is important skill for many gyne and fertility surgeons. Across the year, her skill in gyne ultrasound was appreciated through the invitation and participation as instructor for several ultrasound workshops at Sultan Qaboos University, Boremi, and Royal Hospital. Welcome, Dr. Mariam.
Thank you, Dr. Fatma, for a very kind introduction, and thank you all for participating in this workshop. My talk would be on examining the myometrial part of the uterus. And actually, what I like about ultrasound, besides it's an important skill for my profession, it's actually, I feel it's an extension of my hand. I've been very lucky as a clinician. I take history, I examine the patient, and then I do an ultrasound, and then I do surgery. So the correlation of all these steps together, it builds up into linking them together and see how your eye get trained on what you see on the image compared to what you see on surgery. So when I would like to actually thank Dr. Dina because she laid the foundation for my talk. She made my job much easier than what it would have been. When we talk about the myometrium, we are gonna try and speak about the typical ultrasound appearances of a normal myometrium and recognize the typical ultrasound appearances of common and uncommon abnormalities in the myometrium. So that is related to answering 3 key questions out of this talk, including what are the typical ultrasound findings of a normal myometrium, what are the typical ultrasound findings of common abnormalities in the myometrium, and know when to refer a patient for a specialist opinion. This is the same image that you have seen on Dr. Dina's slides. I think it is an ultrasound transvaginal image of a uterus of a lady in reproductive age, which is before myometrium. As you know, before menopause, I mean, which you know, uterus is a hormonally dependent and responsive organ. So the way it looks will be different from premenopausal to postmenopausal women. In this image, you can see generally you have a homogeneous myometrium. You have the thickness of the anterior myometrium is similar to the thickness of the posterior myometrium with no huge discrepancy between the two. And of course, this is the endometrium. And there is a nice defining line between the endometrium and the myometrium, which is the junctional zone. I would like to refer all the participants to this important landmark paper that is talking or defining the morphological uterus sonographic assessment group, putting or laying down the foundation for the terminology that we use to describe the myometrium normal and abnormal. And this is one of the landmark papers in gynecologic sonography, which I am happy to actually add it to the group of readings, because over years, I think maybe people, they don't appreciate by now, but over years, we did not have the same common terminologies that we are now having with all the gynecologic pathologies. And so I am one of those who appreciates unifying those terminologies together, making our life easy. When describe things, we use a common terminology that everybody understands. We are going to focus on two common pathologies in the myometrium, including the myomas and adenomyosis, and two uncommon, including calcifications and the enhanced myometrial vascularities. I think you guys would appreciate that myomas are really common pathologies that we see, and specifically in Oman, us being genetically predisposed to myomas, it makes it something very important to understand and identify. The Federation International of Obstetric and Gynecology put out guidelines on how to describe myomas, and you can see, as it is here in this image, they are three main groups: the submucous, the intramural, and the subserous. The ones now colored in the pink are the ones that are notorious, and they are very symptomatic usually, despite of the smaller size sometimes. The zero is, they are classified in relation to the cavity. So zero means it is completely into the endometrial cavity, and it is pedunculated. When it comes to type 1, the majority of the myoma is within the cavity, and less than 50% actually of it is into the myometrium. When it comes to type 2, this myoma, the majority of it is actually into the uterine wall, and less than 50% into the cavity. This is very significant for us as surgeons. When we decide to remove the myoma hysteroscopically, then we should be confident that type 0 and type 1 are ones that can be removed, and type 2 depends on other factors. Then the second group, the ones in green, is what is called intramurals, and intramurals are two types: type 4, which is, sorry, type 3, which is just touching on the endometrium, but it does not have a discrete intracavitary component, and this is type 3. In type 4, it is completely within the myometrium, and it does not have a clear relation to the endometrium. In the third group is the subserous one, where you can see in number 5, the myoma, the minimum part of it is bulging into the peritoneal cavity, which is the subserous part, but the majority of it is actually into the uterine wall. Then type 6, where it is more into the peritoneal cavity or subserous component, and a small amount of it is still within the myometrium. When it comes to 7, it is what we call it pedunculated subserous fibroid. There is a fourth group, which we a little bit atypical or hybrid, that includes two main groups. The one that in the past we used to call them transmural, where you have a component of the myoma that is in the submucous. It is bulging into the cavity, it is going throughout the myometrial wall, and then it is partly bulging into the peritoneal cavity. And when we label it 2 to 5. So it has submucous, intramural, and subserous component. Then we have type 8, where it is cervical, or what we call them sometimes also, if they are away from the cervix, these are the atypical group, either in the cervix or away from the cervix, and sometimes they are called parasitic. For example, a complete broad ligament fibroid that is not attached to the uterus by any mean. So these are the FIGO classifications of myomas, and I think it is one of very, very important classification that all gynecologic sonographers or clinicians should understand and use. Beside the location, we need to describe 3 other features about the myoma: the echogenicity on ultrasound, the acoustic shadowing, and the vascularity. Where here in this diagram, we can look into the echogenicity of the myoma compared to the surrounding myometrium. So we use the that myometrium as a baseline to compare. And the echogenicity can be two types. It can be uniform, where the whole lesion carries one echogenic characteristic, or it can be non-uniform, where it is mixed with other, or it is not very homogeneous in echogenicity. When it comes to the uniform echogenicity, it can be hypoechoic, so it is darker compared to the surrounding myometrium. It can be isoechoic, where you can see the lesion and identify it, but its echogenicity is similar to the background myometrium. Or it can be hyperechogenic, where it is brighter on the signal compared to the surrounding myometrium. When it comes to the non-uniform ones, you can find different scale, different gray scale within the lesion, and that is called mixed echogenicity. It can be also one uniform echogenicity, but it has some speckles in it, which is some non-uniform echogenic areas into that. And it can be non-uniformly with cystic areas within the myoma itself. These are real images of trying to use the terminology on a real image. In here, you can see this is this myoma looks darker compared to the surrounding myometrium. So it is hypoechoic. In this one, you can say isoechoic compared to the surrounding myometrium. This I find actually a judgment call. You can call it like it is isoechoic with some hyperechogenicity in it, or it can use the word isoechoic in general. In this one, you can see it is hyperechoic compared to the surrounding myometrium, because it is much brighter compared to the surrounding myometrium. In here, you can see this is a truly mixed echogenicity, where you see different grayscale within the lesion. It can be in here where it has some echogenic areas within it. And in this one, you can see how different echogenicity inside with cystic areas within the myoma. Generally, sometimes we try to call typical or atypical features of a myoma, and that comes with a little bit of experience and knowing the difference into these, what are the features that might be of a concern, and usually heterogeneity and complex look of the myoma, it can raise suspicion that it has some atypical and might be concerning features. So then when we, after describing the echogenicity of a myoma, we need to comment on its vascularity. So in the vascularity, we need to know the normal vascularity of the myometrium in order to understand the abnormal vascularity of the myometrium. So if you understand the anatomy, the arcuate arteries, these are direct branches of the uterine arteries, and then they branch into the radial arteries that penetrates into the myometrium. This is in a sagittal view, and this is in a transverse view. You can see the difference in the images, and this is the corresponding real images when it comes to normal vascularity of the uterus. When it comes to myomas, generally, it has two types of vascularity. A vascularity that is circumferential, which comes onto the pseudocapsule of the myoma, which provides the blood supply to it, and or it can be also intralesional, which blood vessels penetrate through the myoma. And the image on the right just illustrates the how do they appear within a myoma. So this is circumferential blood vessels, and these are the intralesional blood vessels. And these are common features of regular benign myomas. And another layer added to describing the vascularity other than its location, whether it's circumferential or intralesional. It's also trying to describe the degree of the vascularity of the myoma. And in general, this is like an eyeballing score, comes with experience. And it is the same scoring that is being used in other description of vascularity. For example, it is being used in describing scar pregnancy, cesarean scar pregnancy, a similar scoring. So in here, you can see that in score 1, where there is no vascularity visible, score 2, whether it is circumferential or intralesional, very minimal, and in score 3 it is like moderate. It can be circumferential and intralesional also, and abundant, where there is significant circumferential and intralesional Doppler effect. This is an image where they're trying to perform a transvaginal ultrasound describing a myoma in a patient. And you can see the transvaginal probe, and they are trying to stick to what Dr. Dina have described in terms of the technique. So trying to get a sagittal view of the uterus, magnifying the image to the 70% size, depth, and then they're trying to run the Doppler. Actually, they are running Doppler before they are doing the measurement, so I don't think they are sticking to the rules. For me, I see this is the endometrial canal, and you can see there are some fluid inside the endometrium. Now they are measuring the endometrium, so I'm not sure that they are actually measuring the right thing, because I think there is another lesion here that they are trying to measure. And you can see they put a question mark on their measurement, because sometimes it can be challenging to it can be a challenge to actually make sure what you are seeing is the truth, especially when you have a uterus that is distorted by 2 lesions, the one anterior here and the one in here. For me, the endometrium is actually around here. So they are going back to the myoma, and they are trying to measure it in 3 orthogonal planes: the transverse, the longitudinal, and the sagittal one. And they are, of course, they are getting the 3 measurement. And it looks it is a small myoma of around 2 centimeters. And they are labeling it, so people will understand what measurements they have done. This is another image where they are trying to identify the true endometrial canal. So they are trying to line the endocervical with the endometrial canal, and they're trying to get the measurement. And you can see these are several lesions in the same patients. These are 2 anterior and 1 posterior here, and it might be challenging to actually get an accurate endometrial measurement for such a uterus. But they are trying. And you can see they actually saw a cyst while they are screening through the uterus and the scanning, but they did not get distracted by that cyst. They are still systematic. They are trying to complete their evaluation of the uterus before they get to the adnexa. They are not gonna ignore the ovary completely, but they are gonna look into it after they finish the evaluation of the myometrial lesions that they are planning. And here there is an assessment of the vascularity of the uterus and of the myoma, and you can see this is a circumferential vascularity of, maybe I would give it a grade 2, a score of 2. And here they are making the measurements of the myoma in the 3 planes. Of course, the machine can give them the volume, the total volume of the myoma, but in general, as surgeons, we get used to the actual the thought of the size rather than the volume. Then we are here talking about another pathology in the uterus, which is the adenomyosis. So adenomyosis is, as everybody knows, it's the abnormal presence of the endometrial tissue within the myometrium. So the same lining of the uterus, tissue of it, it is present within the myometrium. These are common features that we see in adenomyosis. These features include a globally enlarged uterus in general. You can see there is a discrepancy between the thickness of the anterior wall and the thickness of the posterior wall, indicating that adenomyosis is present more in the posterior wall. There is a fan-shaped shadowing that happens as a result of the presence of the endometrial tissue within the myometrium. You can also see myometrial cysts, and these are hypoechoic cysts in hypoechoic areas within the myometrium. And you can see also poor junctional zone, or the endometrial myometrial border can be thickened, it can be absent or interrupted. And these are common features that we see in adenomyosis. So in here, you can see the globally enlarged uterus with hardly any junction between the endometrium and the myometrium. Here you see the discrepancy in the size and thickness between the anterior myometrium and the posterior myometrium. One funny thing about ultrasound is trying to give an image that will make you remember a characteristic feature of some pathologies. Like, for example, I don't know what people would think of this picture, but it looks like rain in the forest. If you agree with that. In Oman, maybe we don't have forest, but imagine that you are in a palm tree farm and it started raining on you. I always make an analogy with snowstorm appearance of a molar pregnancy, where we don't have snow, but we can have sandstorms. So it's a similar thing. So you can imagine it describes fan-shaped shadowing of the endometrial glands within the myometrium. And that is because of the varying density of this tissue within the myometrium, because they are not all same density. And so it gives a fan-shaped characteristic shadowing that is called rain in the forest sign. These are myometrial cysts. Sometimes these are filled with fluid or just endometrial cells without actual fluid. They can be deep in the myometrium, or they can be sub-endometrial. And these cysts in general, they are avascular when you run the Doppler on them. In the most right-sided image, it shows how distorted the junctional zone, or the endometrial myometrial junction. It is fuzzy, it is almost not existing, and that tells you that is not a healthy area between it's not a clear demarcation between the endometrium and the myometrium, and this is a characteristic feature of adenomyosis. So we spoke about two common pathologies in the myometrium, which are myomas and adenomyosis. Now we talk about two relatively less common, including myometrial calcifications and enhanced myometrial vascularity. Of course, it's very important before you scan, you have some sort of history, some sort of what exactly the patients complain or what is her story. That will help you interpret the images that you see. What you see in here it is a small, this is a transvaginal probe showing a small uterus. And in this small uterus, hardly we can make the endometrium. And these are calcifications, spical calcifications on the periphery in the myometrium, and these are this is in a longitudinal, plane, and this is in a transverse plane, and both are showing the same thing. And these are calcifications corresponding to old vessels in the myometrium. And this is very common in postmenopausal women because of the estrogen absence results in a significant atrophy and decreased vascularity and thickening of the and calcification of the blood vessels within the myometrium. This is then describing the vascularity of the myometrium is important because the concept of enhanced myometrial vascularity, as you have seen before, we showed images of what a normal vascularity of the uterus looks, of the myometrium looks like. There are situations where there is enhanced myometrial vascularity. One of common things that in this is seen when the blood supply within the myometrium is very rich, and it is supplying most likely an area that needs enhanced blood flow or blood supply, and that is a characteristic feature of the retained product of conception. Why? Because this enhanced vascularity area within the myometrium is in direct contact with endometrium. And of course, you will need some history that this lady is pregnant, post miscarriage, something like that. And that is to differentiate these abnormalities, whether it is vascular malformation, or is it just enhanced vascularity because of the retained products. Taking a comment on the vascularity of the myometrium from just enhanced vascularity to actually measuring the peak systolic velocity, where people are using it to predict, for example, in retained product of conception, to predict that high peak systolic velocity might predict the need for surgical evacuation of the patient instead of waiting for spontaneous or expectant management. And so that can guide the clinician thinking towards what way they are gonna manage this patient. This is a video illustrating the same, where they this is a transvaginal ultrasound, so they magnified the image on the screen, and they are running the Doppler color flow, and you can see here they are measuring the peak systolic systolic velocity. But this is not a standardized way. It's not, there is no international agreement on it, but some clinicians can use it as a guide towards managing patients. So just to give a flavor that this feature can be utilized in guiding the clinical management. Again, we are going to go back into summarizing how do you actually look at the uterus and the myometrium. So you measure the uterus in the 3 orthogonal planes, the same that Dr. Dina showed and explained. So, and she was very very particular about you taking away that message. It is very important to be systematic and measure do your measurement in the correct way. Assess the symmetry of the myometrial walls, anterior and posterior. Assess the echogenicity, whether it is present or absent, whether what type is it, homogeneous, uniform, or mixed echogenicity. Assess the presence or absence of myometrial lesions, whether they have a well-defined border or not having a well-defined border. A well-defined border will be more suggestive of a myoma, and ill-defined border may be more suggestive of adenomyoma. assess the lesions as a whole. Where are they? How many of them? What are their sizes and locations? Assess the vascularity, and it will be good if you can give it a score, whether this is a peripheral vascularity, circumferential, or it is intralesional. And then try to find, give more specific locations to the myomas, and in particular mid-sagittal plane and transverse. They can give you that idea, but adding a 3D ultrasound will definitely enhance, and it have enhanced our ability to identify myomas, whether more they are in terms of the location specifically, and importantly in relation to the endometrial cavity. And I think the more people using 3D, the more they drop the number of MRI scans that they are requesting for specific lesions. They are rising concerns regarding suspicious lesions and non-suspicious lesions. And unfortunately, we don't, especially in myomas, and that affect especially us as surgeons, when we do ultrasounds when we do myomectomy, we always want to think and decide whether it is safe to morcellate and cut this myoma inside the cavity, the abdominal cavity, or not. And so that is becoming important to assess the sonographic features, whether they are typical or atypical. So whenever there is an atypical feature that is of a concern to you, refer the patient to a specialist who can provide some more expert opinion on whether this lesion is more towards malignancy or more towards benign. And the more we do, the more we try to learn and understand the atypical lesions that might come, and always are on the side of caution. When we have atypical features in a myoma, then it is better to refer the patient for further assessment. One of the important things, and also mentioned in the previous lecture by Dr. Dina, and I am very happy that now we have standardized guidelines and consensus statements on how to describe gynecological lesions. We have been little late compared to the obstetric side, but I think we are there now. We have international guidelines to describe adnexal masses based on IOTA. We have guidelines to describe endometrial lesions based on the IATA. We have description, as we have seen, for the myometrium based on the MUSA, and we have international guidelines to describe deep infiltrating endometriosis, like in IDEA. So these guidelines actually makes us understand and communicate better about these lesions. And as I have mentioned before, whenever you have atypical features on ultrasound for any of these lesions, it is better that you refer a patient for further evaluation. And you can see actually the word second opinion, for me, it doesn't mean a complete transfer of a patient. Sometimes we are in the same institution. We can call each other, come see this lesion. What do you think about it? What it is most likely? So we learn together, and that actually increases and fasten our learning curve with different lesions that we see. So you can do it, depends on your clinical setup and depends on what are the resources available to you. And that's the end of my talk, and hopefully, inshallah, we will come your questions in the Q&A session. And thank you very much.
Thank you, Dr. Mariam, for this interesting presentation. And now we will go for prayer break, and we will join after 15 minutes.
Inshallah.
I think that here we can start. Dr. Fatma around? Dr. Fatma?
She's there.
I think we can start.
السلام عليكم.
عليك السلام.
رجعني مرة ثانية. Okay, welcome back. Welcome all of you. And now we will go with Dr. Divya to talk about another important anatomy, which is the ovary. Dr. Divya, she is a consultant radiologist in prime imaging and prenatal diagnostic in Chandra. She is Obgyn ultrasound content expert in Talon umbrella organization of ARDMS in USA. She is a member of ISUOG CME task force. She is member online education working group of ISUOG. Welcome, Dr. Divya.
Thank you, Dr. Fatma, for the kind introduction, and good evening, everyone. Moving forward, today's gynecology ultrasound program, I'll be talking about examining the ovaries and adnexa. At the end of this lecture, you will be able to understand the terminology proposed by the International Ovarian Tumor Analysis, that is IOTA group, and certain definitions and measurements of, you would learn how to measure ovarian or adnexal lesions. The key questions which I hope to answer in this presentation include how to describe ultrasound findings when you see an ovarian lesion or an adnexal mass using the standardized IOTA terminology, how to measure different components of an adnexal lesion, and how do you assess and describe vascular flow in adnexal lesions. So we'll basically understand the IOTA terminology, learn how to assess and measure the different components of an adnexal lesion, and understand how to adjust the ultrasound settings so as to assess vascularity in ovarian lesions. Coming to the standard terms, definitions, and measurements proposed by the IOTA group, these are as follows, and I'll be discussing each of these headings one by one. Now, what is an ovarian lesion? As per IOTA terminology, an ovarian lesion is part of an ovary which is inconsistent, that is, which is not consistent with normal physiology. So if you see a corpus luteum within an ovary, would that be an ovarian lesion? No, because corpus luteum is consistent with normal physiology, and an ovarian lesion is something which is not consistent with normal physiology. Similarly, an adnexal mass is a mass in the adnexa which is not consistent with normal physiology. Then coming to the IOTA definition of a solid component. Now, a solid component is a structure which has high echogenicity, an echogenicity which is suggestive of tissue. Now, what is the reference that we use for tissue echogenicity? That can be the myometrium, the ovarian stroma, the echogenicity of myomas or fibromas. So any structure which has an echogenicity similar to these tissues would be suggestive of a solid component. What about the white ball of a dermoid? You can see these are all examples of dermoid cysts. The white ball of a dermoid is composed of hair and sebum, as you can see in this gross pathology image. And this is not to be considered as a solid component because it's not actually composed of solid tissue or cells. Similarly, according to IOTA definition, a blood clot or amorphous material within an endometriotic cyst should also not be considered as a solid component because it doesn't have solid tissue. However, sometimes there can be confusion within the ultrasound appearance of a blood clot, and it needs to be differentiated from a solid tissue. As you can see, these are all unilocular cysts in these images, and they are actually all hemorrhagic cysts with different kind of appearances. Here you see there is presence of a slightly hypo to increased, that is a mixed echogenicity kind of a lesion seen in the non-dependent part of the cyst. There are thin lacy fibrin strands here. This irregular, bizarre kind of hypo to increased echogenicity kind of a lesion. And you need to differentiate whether these are blood clots or solid component. So how do you do that? You can do this either on 2D, that is on grayscale, by simply pushing on the lesion with your transvaginal transducer. So when you push on the lesion, if the solid looking component or the area of increased echogenicity within that cyst moves, then it is suggestive of a blood clot, because blood clot is something which is friable and it tends to move when you apply gentle transducer pressure to a hemorrhagic cyst. On the other hand, because solid component is firm, it will not move when you press the lesion with the transducer. Also, you can use color Doppler to differentiate solid component from blood clots. This is because if you switch on color Doppler, if a particular structure lights up with color, that is, it shows vascularity, it means it confirms that that is a solid component. However, the vice versa is not true. That is, if you see an area of high echogenicity, put on color and it does not show vascularity, it does not mean that 100% this is a blood clot, because sometimes even a solid component may not show vascularity. For instance, if your Doppler settings are not correct, the PRF is too high, you may not see vascularity. Or if the solid component has got very slow flow, which cannot be picked up by Doppler, then again, you may not see vascularity. And also if a solid part is a bit far away from your transvaginal probe, then it may not pick up color. So presence of color confirms that there is a solid component. The absence of color does not rule it out completely. So if you are in doubt, if by using both grayscale and color Doppler, you are not sure whether it's a clot or a solid component, it's always better to err on the side of caution, because we don't want to miss out a malignancy. It's better to classify that material as solid tissue. Now just see these two lesions here. They are both unilocular, and you can appreciate this higher echogenicity stuff within both these lesions. Now, is this solid component or blood clot? Let's see. Now, if I push upon with the transducer probe on this lesion, you can appreciate how the material, the increased echogenicity material, shows movement. So this is a blood clot and not a solid component. Similarly, see the second lesion. When we are pressing with the ultrasound probe, this content within this unilocular cyst is moving. It is just a friable blood clot and not a solid component. Then I've switched on color Doppler here on this increased echogenicity component in this unilocular cyst, and this is not showing vascularity. This is a blood clot. If I would just push this on grayscale, this will move. So this is a clot. And this is again, just to show you the typical appearance of a blood clot on still image. It's not showing any vascularity. But remember, we are not relying only on color Doppler to confirm that this is blood clot. We are also going to push on this to confirm that it moves. Coming to iota definition of a papillary projection. A papillary projection is any solid protrusion into the cyst cavity which has a height of at least 3 millimeters or more. It's important to identify papillary projection because papillary projection is considered as solid tissue according to iota definitions. These are all examples of papillary projections seen within cysts. You can see how they have a higher tissue echogenicity. They are considered as solid component and they are being called as papillary projections because all these lesions have a height of 3 millimeters or more. You can appreciate them here in grayscale. You can see how this papillary projection is not showing vascularity on color Doppler, but this is still a solid component. And this is the appearance of papillary projections in 3D rendered images. Now, what if the height of this protrusion is less than 3 millimeters? If it is less than 3 millimeters, it is not considered as a papillary projection, but is just termed as cyst wall irregularity, as you see in these images. So this is not a solid component, it is merely cyst wall irregularity. Coming to iota definition of septum and incomplete septum. Now, septum, or in other words, complete septum, is a thin strand of tissue which runs from one internal cyst surface to another, as you see in this image. You see this strand of tissue which is extending from one cyst wall to the other on the opposite side. Its importance is that because there is a complete septum here, this lesion is multilocular. On the other hand, an incomplete septum is a thin strand of tissue which does not reach the opposite wall of the cystic structure in some scanning planes, for instance in hydrosalpinges. As you can see here, this is an anechoic lesion, and you see these incomplete septations which are definitely not reaching the opposite wall. Again, example of incomplete septations which are not reaching the opposite wall. So incomplete septations are typically seen in hydrosalpinx, and if you see incomplete septation, the lesion is termed as unilocular. Now, based on the appearance, lesions are of 5 types. First is unilocular. Coming to unilocular, as the name suggests, unilocular means the cyst has got single locule, and there is no complete septation, no solid component, irrespective of the type of fluid present in the cyst. These are all unilocular lesions, and you can see none of them has a complete septation, nor does it have, excuse me, any solid component. What about unilocular solid? As the name suggests, the cyst would have one locule along with some solid component. As you can see here, this is a unilocular solid lesion because here is this papillary projection, and of course, presence of papillary projection is equal to there being a solid component, making this lesion unilocular solid. Multilocular, as the name suggests, lesion would have multiple locules because of presence of complete septations. As you see here in this image, there is this multilocular lesion with multiple septations. It's called multilocular because there is no solid component seen here. However, if you were to see solid component within a multilocular lesion, solid component like this, then it would be termed as multilocular solid. And finally, coming to the solid appearance. As the name suggests, and you can see in this image, most of the lesion is solid. However, sometimes you might see certain lesions which would show mixed solid cystic appearance. So how do you decide whether they are solid or cystic? Well, a lesion is solid if it has at least 80% or more of the solid component within it on 2D. So if a lesion is mixed solid cystic, if it has more than 80% solid component, it's termed as solid. Coming to the contents of cyst. Now, contents of the cyst can be anechoic, that is completely uniformly black, as you see in this image. Anechoic contents are typical of functional ovarian cysts as well as serous cyst adenomas. Then the contents can be low level. By low level, I mean these punctate white echogenestes that you see in this image, and you can appreciate these echogenestes moving in this clip. I hope you can see how these punctate echogenestes are moving. This is described as low-level cyst content. And this content is quite typical of mucinous ovarian tumors. As you can appreciate, these are the hemorrhagic contents, the lacy fibrin strands, which are typical of a hemorrhagic cyst. And on gentle transducer pressure, you can note how these fibrin strands are moving, confirming that they are just fibrin strands and not thick septations. As the name suggests, mixed contents would have mixed kind of echogenicity. So there would be echogenic areas, relatively less echogenic areas, areas of shadowing. This is quite typical of a dermoid cyst. And finally, the ground glass appearance, which is very characteristic of endometriomas. Now let's talk about acoustic shadowing. Acoustic shadowing is something which is very important to see because acoustic shadowing is actually a feature which is suggestive of benignity. You have to look for acoustic shadowing behind the contents within the cyst as well as behind the whole lesion. For example, in this image, you can see the acoustic shadowing behind the white ball in a dermoid cyst. Why does this occur? Because there is attenuation of the sound beam when it strikes this white ball, and you can appreciate this posterior acoustic shadowing behind the content of the dermoid cyst. In contrast, just look at this lesion. This is an ovarian fibroma which has replaced the ovary, and there is this acoustic shadowing seen behind the entire lesion, again because of attenuation of the sound beam. So always look for acoustic shadowing in adnexal lesions. Then irregular cyst wall. Irregular cyst wall refers to the irregularity in the internal wall of the cyst or there can be irregularity in the outer contour of a solid lesion, as you appreciate here. Also, if a lesion has a cystic component in a solid tumor, you can appreciate the irregularity in the cystic component. So these are the various forms of irregularity which you can see in an adnexal mass, either in the inside of a cyst, in the inside of a solid cystic tumor, or along the outer contour of a completely solid lesion. Coming to color score. Next, we look for vascularity. Now you can give a color score ranging from 1 to 4, depending on subjective assessment of blood flow. So if you do not see any blood flow within the solid component, you give a color score of 1. If you see minimal blood flow, color score is 2. Color score of 3 is for moderate vascularity, and the color score of 4 is for marked intense vascularity when the entire solid component lights up with color. Before using the color or power Doppler, it's important to understand the use of two knobs, which I'm sure you know by now. That is the PRF, pulse repetition frequency. While assessing adnexal lesions, the ideal PRF should be between 0.3 to 0.6 kilohertz. So it should be lower than this. And you have to know how to use the color gain. The importance of pulse repetition frequency is understood here. Now, this is the ideal pulse repetition frequency range, which you should use while assessing adnexal lesions. If you use too low a PRF, well, there will be aliasing, and as a result, you would see haphazard color inside the entire color box, and even you can see the cystic areas are showing color, which is all artifactual. Now here, if you were to see the lesion, you would give it a color score of 3, but if you were to use too low a PRF, you would end up giving a false color score of 4. So to get the correct color score, use the correct PRF settings. If you use a very high PRF, as you see here, then you will not be able to pick up the slow flow in the lesion. And here you would end up giving a color score of 1 or 2 when actually the color score is 3. So this is the importance of using the correct PRF. If it's too low, you get aliasing. If it's too high, you miss the vascularity. Once you've fixed the PRF, say at 0.3 kilohertz, then you adjust the gain. You can always initially increase the gain so that the gain is more than what is required, as you see in this first image. The color is kind of filling up the whole box. And after that, you start reducing the gain by adjusting the knob such that the color doesn't occupy the entire box in this fashion and is confined to the solid area of interest, as you see in these images. So you can work from excess gain, reduce it slowly till you get the optimal gain. Coming to ascites. Now we know that there can be some amount of fluid in the pelvis of premenopausal women. It is termed as ascites, that is, the fluid is significant when the fluid is outside the pouch of Douglas. That is when the fluid is either above the level of the uterine fundus, or you see fluid in the anterior compartment, that is in the utrovesical compartment. Then it is termed as ascites. Now you've learned how to describe an ovary, how to describe a solid component, how to describe a lesion. Let us learn how to measure these things. As we all know, we need to take 3 dimensions of every structure. So whenever you are to measure a structure, for instance, if it's an ovarian lesion, an adnexal mass, an ovary, always first get that plane in which that lesion measures the largest. For instance, this is one unilocular lesion, and here we've taken it where the lesion appears to be the largest. And the first dimension that we will take will be the maximum diameter. The second dimension can simply be taken by drawing a line perpendicular to it. So this is the second dimension. And to get the third dimension, all that I need to do is just rotate my transducer 90 degrees from this plane to get this plane, and then take this side to side third measurement. Once I have all these 3 measurements, I just need to multiply them and then multiply these with 0.5, because this is the formula for calculating the volume of an ellipse. And this would give me the ovarian volume or the volume of the ovarian or adnexal lesion. How to measure a papillary projection? This is also important. We measure papillary projection in 2 dimensions. We measure the height of the papillary projection and the base. Note that when we are measuring the height, we should not include the cyst wall thickness. And this is how we measure the height of the papillary projection, because if you increase the cyst wall, then you would get a falsely increased height, and you might end up calling an irregularity as a papillary projection. So do not include the cyst wall when measuring the height of a papillary projection. These are just examples to show you how to measure the height and base of the papillary projection. Note, the cyst wall has not been included while measuring the height of these papillary projections. How do we measure the maximum diameter of the largest solid component? It's very clear. Whenever you see a solid component and there are multiple solid components, first identify the largest solid component. Once you've seen the largest solid component, you just need to calculate the maximum diameter. So the statement is self-explanatory. You see the largest solid component and get its maximum diameter, as you can see in all these 5 images. Now I'll come to the key points of this presentation. I hope by now you've understood how to use the standard IOTA terms and definitions, because it's important that all of us, whether we are in India, Oman, UK, US, Canada, speak the same language so that we understand what we are talking about when we are treating our patients. And also when we are doing research, that is when we are writing papers, all of us use the same kind of terminology. There are 5 types of ovarian lesions: unilocular, unilocular solid, multilocular, multilocular solid, and solid. A solid component, as you know by now, is a structure which has high echogenicity, similar to ovarian stroma or myometrium, which is suggestive of tissue. A papillary projection is considered as a solid component, and it is something which protrudes into the cyst wall and has a height of more than equal to 3 millimeters. If it is less than 3 millimeters, it is just a cyst wall irregularity. And when you're using color Doppler, please bear in mind that the PRF should be between 0.3 to 0.6 kilohertz when assessing adnexal masses, and you must optimize the gain. Thank you.
Thank you, Dr. Divya, for this informative presentation. It is very clear and it is very also short. Good. So it is comprehensive presentation of ovarian. And now we will move to the next topic, which is about how to write the report. This talk will be done by Dr. Saada Al-Subhi. Dr. Saada Al-Subhi, she is graduated from Sultan Qaboos University. She is specialist obstetric and gynecology, and she is also national training of ISUOG. Welcome, Dr. Saada. You can start.
Thank you, Dr. Fatma, for introducing me. Hello, everyone. Coming to the lecture of writing the gynecological ultrasound report. This is an issue which is very much related to the previous three lectures that you have gone through. And I think many of us think that spending little bit of time to write down a good, concise Gyne report is not important. Or maybe we find it so boring to do that. But actually, remember, if you spend time to do a thorough, systematic Gyne ultrasound examination, the way it has been explained to you by Dr. Dina, you want to translate all your findings in the form of a good, concise report, so that you can convey whatever you can you can convey whatever you want to convey in a nice way, in a good, understandable way. So hopefully by the end of this lecture, you will be able to write a clear, concise, and accurate gynecology ultrasound report. You will also understand the importance of writing a good Gyne report and understand as well the basic principles of Gyne ultrasound report. And the key features which are going to be addressed during these lectures are the key questions which are going to be addressed are what are the key features that need to be fulfilled when writing a Gyne report, so that you ensure ending up writing a good and a concise report. So what is an ultrasound report? Why is an ultrasound report important? First of all, it's a medical legal document. It's like any other patient's notes, but we tend to document and refer back whenever we need that. So it's a medical legal document. Remember that it's a main way of communication between the sonologist, the referring clinician, and the patient, especially in institutions where the clinician has to refer the patient to some other person to do the ultrasound for him or for her. So at the end, the sonologist has to give a report, and the clinician is going to rely on whatever the sonologist writes on that report. So it's the main way of communication. It constitutes a clinical opinion of a specialist interpretation of images, so it carries crucial information. Therefore, the aim of your report at the end should be to answer original clinical question and provide information patient management. It shouldn't be a vague report. It should answer the clinical question. That is why the patient has presented to me, why is the patient referred to me, why is the patient here, why do I have to do the scan for her? For example, if a patient presents with a history of amenorrhea and right iliac fossa pain with positive pregnancy test, and she's referred to me for a scan, then at the end of my scan, and after I write that, my report should answer why is the patient, for example, having this right iliac fossa pain. Do I have to rule out while I'm doing my ultrasound examination? Do I need to rule out or rule in an ectopic pregnancy? Am I dealing with some other pathology in the adnexa, for example, and it's a viable intrauterine pregnancy? So your report at the end should answer the clinical question. And it should be, therefore, an accurate, clear, concise, and logical report. So before you examine your ultrasound, your gyne ultrasound examination, as I said, you should know why is the patient referred to you, or why do you want to perform the scan for her? What is the clinical presentation? And while you perform your ultrasound examination, remember that if you notice any clinical observation, it is very important to state that in your report, because it might help the clinician to guide her plan of management. For example, if you notice probe tenderness while you are performing your ultrasound examination, then it's very important to state that in your report, because it might guide in the plan of management, especially if we correlate everything together. We correlate the ultrasound findings, the clinical presentation, any additional observation. And of course, at the end of your ultrasound examination, you want to come up with findings. You want to write them in a good report. You end up your report with a good conclusion, good concise conclusion, and coming up with the possible diagnosis or possible differential diagnosis and the suggested plan of management. Here are the basic guidelines for writing a gyne report. Remember that the report should be issued and written by the sonologist who performs the ultrasound examination. It shouldn't be done by anyone else. It shouldn't be allocated to a junior doctor to write it. Remember that it's an integral part of the entire examination. It's a medical legal document, so it has to be written by the one who does the ultrasound examination. It should be written as soon as possible after the examination is completed. It's not that you perform an ultrasound examination for 4 or 5 patients and then you leave the reporting to the end. You might get confused with the different findings of the patients. You might even forget important findings. So make it a habit to write it as soon as possible after your examination. Remember that if you are the one who's performing the ultrasound examination, you are fully responsible for the accuracy and the content, and it's a medical legal document. And it's always advisable that the sonologists are aware of their limitation and seek advice where necessary. Whenever you face a difficulty while you perform your examination, it's always recommended to state the difficulties that you have faced. Is it because you are not that much skilled? Or is it because there are technical limitations, like you are dealing with morbidly obese patients, or there are many overlying bowel gases over the adnexa, that's why you cannot visualize them. So it's always important to state the limitations, or to mention whatever you could not assess, other than giving wrong findings upon which clinical decision can be taken. And always remember, you can ask for help, you can always discuss, you can even suggest what is next step to be done. That's all recommended, rather than giving wrong findings upon which a wrong clinical, a long judgment is going to be taken. To continue with the basic guidelines of writing a Gyne report, most of our reports nowadays are printed, but if it is handwritten, it should be in black ink for the clarity of the handwriting. Report must be appropriately dated, signed. The reporter's name should be there and designation, and it should be filed in the medical records of the patient. It's a very good idea to use a pre-existing template or electronic database. If there's an electronic database or pre-existing template, it helps to maintain consistency of the reporting, because everyone is going to fill the information which is there in the template. It's going to be, the information is going to be filled in a very organized, systematic way. It allows research. The information which is there stored in the database allows research and audit to take place, because it's always there and it's organized and it can be retrieved at any time needed. Having a database in the institution ensures that everyone is following the local standards of the institution, the local standards of the unit, in the way they fill the information. So it becomes easy to be followed, to be read, to be retrieved at any time. That were the basic guidelines of writing a good Gyne report. Just look at this report. I hope nobody is writing such a report nowadays. Actually, this is an over-exaggerated example, but I'm sure nobody writes like this now, and I think everyone agrees it's an acceptable report. That's all. On the other hand, if you look at this electronic database, this is an example of an ideal electronic database. The template is there, the headings are there, the sonologist has to fill up the findings in this database. So as I said, it allows adherence to the local standards of the institution. So the information is organized and easy to retrieve. Not only that, it makes it can even remind you, did I do this? Did I do this? Or I haven't done this. So even if the template itself helps in reminding you if you have missed anything, because sometimes you cannot even save it unless you go back and do whatever you haven't done. So this is a good example of an ideal database. Coming to the report style, remember that your report should be clear and concise. Use present tense. The report should be easily understood using standardized terminology. Avoid using technical jargon and avoid using abbreviations which are not understandable at all. State on your report any actions or recommendations that you feel like any actions or recommendations from your side should be clearly reported, and you should end up your report by writing a succinct conclusion. You end up your report by writing a brief, concise conclusion, because sometimes the report is too long and contains lots of measurements. So it becomes so boring just to read the whole thing. So it's always good to summarize the whole report in a short conclusion, contains 1 or 2 sentences, and this conclusion carries all the positive findings, carries the possible differential diagnosis, and your own suggestion of what is the further plan which is recommended. And remember that report should be conclusive where possible and indicate when the appearances are consistent with specific diagnosis. The message here is that if you can give a diagnosis or differential diagnosis, that is great. But if you cannot, don't worry. Remember that you can always ask for opinion. You can always discuss with another with a senior person. You can always suggest the next step to be taken. So do not try to make assumptions, and do not try to write wrong findings which are not sure of. Here are the contents of your report. At the end, your report should include clinical history, structures that have been examined, the description of your findings, your interpretation of the findings, and the report is summarized in the form of short summary with 1 or 2 sentences. Part of the report contents is certain details, personal data about the patient, and some technical details as well are important to be clear in the report, in the Gyne report of the patient. Of course, patient's name, date of birth, or the age of the patient, this will all be there in the template. The name of the sonologist, the name of the chaperone. This is applicable to institution where a male doctor has to perform the transvaginal ultrasound. So if a male doctor has to do that, it is always advisable that the chaperone is there and the name should be documented. Where was the scan performed? What type of ultrasound machine has been used? What type of examination method? Is it transvaginal, transabdominal, or transrectal, for example? Or is it a combination of more than one method? Always state the indication of your scan. What is the clinical question? Why you are performing the scan for the patient, or why is the patient is here for the scan? And state any limitations, as I said, for example, body habitus restricting the views, or overlying bowel gases restricting the ethnicity. Some vital information as well should be included in the basic history of the patient, because this type of information will affect the way you interpret your images. For example, the last menstrual period, even Dr. Dina has mentioned that the findings would differ according to the time that you perform your ultrasound based on the menstrual cycle. So all this has to be documented, like the last menstrual period, the length of the menstrual cycle, is the patient pregnant or not, or is there any recent history of pregnancy and abortion, the parity of the patient, is your patient menopause, is she on any contraception, or is she on any hormonal replacement therapy? Because all this might affect your interpretation of images. So this type of information also need to be reported and documented. So that was all about the basic guidelines of writing a Gyne report, about the report style and the contents of your report. Now coming to the examination outline of the individual structures. Actually, this has been introduced to you very well by the previous speakers, by Dr. Dina, Dr. Divya, and Dr. Maria. And I don't have to go into the details of all this. But the message here is that after you do your thorough systematic examination of the individual pelvic structures, you want to translate all your findings, and you want to translate all your findings in the form of a good, concise report. So here I'm just showing you what you are supposed to describe when you write your report for the individual structures, but it has been all introduced and explained to you how actually to assess all these structures, how to take the measurements, and how to describe any pathology notice. So to start with the uterus, and we should always emphasize that, make sure that your probe orientation is correct, and the dot on your screen is on the left-hand side of the screen. The dot is on the left-hand side. Starting with the uterus, you have to describe the orientation of the uterus in terms of version and flexion, as Dr. Dina has explained to you. What's its position, the size of the uterus, and it was all explained how to measure it. What is the general eco-texture of the uterus, the shape and the contour, is it regular or lobulated? And always good to assess its mobility and the sliding, whether it is sliding over the underlying bowels. Coming to the endometrium, you have to assess the endometrium. Is it visible or not? If it is not visible or not accessible, you have to know why it is not that. Is it because of the location, or is it because of the presence of some pathology obscuring it? And if it is visible, then you need nicely to describe its thickness and its appearance. And you have to correlate, of course, the thickness of the endometrium with the menstrual status of the patient, or with the postmenopausal status of the patient. And pay attention as well, if the patient is on certain medications that can affect the thickness of the endometrium, like tamoxifen, for example, then you should state that and correlate the things together. Assess the endometrial myometrial junction, the way it has explained to you before, regular or irregular, is it interrupted, or it's not accessible because some pathology is there. Of course, if there's any focal pathology like fibroids, polyps in the endometrium, then you have to describe them thoroughly, locate them, and describe them thoroughly as it was introduced before. Coming to the assessment of the myometrium. Assess the overall myometrial echogenicity. Is it homogeneous or heterogeneous? Focus whether there are any diffuse or localized abnormalities like fibroids, adenomyosis. If there are any, you have to localize them and you have to measure them and describe them thoroughly. The cervix, of course, we do not report, if we do not write anything about the cervix if it is of normal look, but if there's anything noticed in it, like Magbotian follicle, like, for example, a very obvious cervical polyp in the canal could be visualized. So it's always, you have, to state that. And as it has been introduced to you earlier, any abnormalities noted in the endometrium or myometrium, report using AITA and MOSA terms and definitions. These abnormalities, in the endometrium and myometrium, should be reported using the AITA and MOSA terms and definitions. Now, coming to the examination of the adnexa, remember that you have always to be systematic in your examination. And Dr. Dina has emphasized on that at the end of her talk. Be systematic. With the adnexa, start with the right side, then move to the left side. Both adnexa must be examined. Size of the ovaries should be measured in 3 orthogonal planes. And if it is relevant, then comment on the number and pattern of the follicles, of course, according to the clinical question that you are trying to answer. Assess the mobility of the ovaries, whether they are mobile, or there's some fixation, or there is fixation to the uterus bowel or the pelvic side walls. Tenderness, if you have noticed during your ultrasound examination any tenderness, then always state that and comment on that, because that's very important. And as I said before, it might guide in the clinical management as well. And remember that you can always use your free hand to examine for any bimanual. You can do your bimanual examination while you are performing your ultrasound examination to locate, to notice any tenderness. Coming to the fallopian tubes. Of course, fallopian tubes are not visible, but sometimes if there's some pathology in them, like hydrosalpinx, hematosalpinx, biosalpinx, they might be visible. So any abnormalities or any adnexal masses should be reported using the IOTA terms and definitions, and this has been explained thoroughly to you by Dr. Divya. Pelvic fluid. There is no standardized cutoff value of the amount of pelvic fluid but the amount and the location are important for us with the correlation of the clinical picture, of course. For example, little bit of clear fluid on the pouch of Daclos is, I wouldn't be worried about that at all. But if you notice extensive fluid in the uterovesical folds or adnexal region, and then it would be of clinical significance, especially if you correlate that with the clinical picture of the patient. Of course, the appearance of the fluid also is significant. If it is anechoic fluid, I wouldn't be so worried, but if it is echoic or low level, in keeping with clots or blood, then it would be of clinical significance. Now, if you notice any pelvic mass, remember that if it is a large pelvic mass, you have to combine your transvaginal ultrasound examination with transabdominal examination, because it is not possible to capture the whole mass just by transvaginal ultrasound examination. So you have to combine the two together, and by doing the transabdominal scan, you can visualize the whole mass and you can take the proper management. If a gynecological malignancy is suspected, it is good practice to complete a full upper abdominal survey, like to go and assess the kidneys, the liver, the spleen, and the peritoneum. This is, of course, if the sonologist is expert enough in doing that, if she's experienced enough in doing that. But if she's not experienced in doing that, she can always refer to the specialist. But it would be good also if she recommends that. That's why we said at the end of your report, just recommend what is the next step you feel like it has to be done. So at the end, after assessing all the individual pelvic structures, and you write down your description of the individual structures, you end up your report by writing a short, concise summary, where you mention the positive findings, the possible diagnosis or differential diagnosis, and what do you recommend next. Okay, so that we end up writing a good and a concise report. So that was all about how to write a good and a concise Gyne report. Let's analyze some cases and see how are the reports written and whether they fulfill the basic guidelines or not. Here is a 37-year-old lady, previous 2 normal deliveries, presented with irregular vaginal bleeding for the last 3 months. Her urine pregnancy test is negative. This is all the clinical information that we have about the patient. The patient had an ultrasound. The report states that uterus is anteverted, echogenic focus is seen with a feeding vessel, normal appearance of both ovaries, no masses or free fluid seen. The conclusion is that ultrasound findings demonstrate an echogenic focus within the uterus with a feeding vessel. Just have a look at this report. What do you think about it? Is it conclusive? Is it concise? Does it answer your clinical question? Does it fulfill the basic guidelines that we have gone through earlier? Let's analyze it. Let's start with the positive points about this report. It is in a concise style, yes. No ambiguous terminology used at all. No inappropriate technical language. There isn't any irrelevant information. But no limitations have been stated. Like it seems that nothing has been stated about any limitations. Does it address the clinical question? Well, it describes this an echogenic focus in the endometrium. What is the size of it? No mention of that. What it could be? What it could be? No mention about that at all. So it's left to you. It's left to whoever reads the report to decide what he wants to think of. So it does not actually address the clinical question. I agree that no abbreviations and no understandable abbreviation used at all. But overall, as I said, no measurements given, no measurements given for any of the individual pelvic structures, no measurements given even for the pathology which is noticed. and it doesn't give the possible diagnosis. It does not give a differential diagnosis. So overall, we can say it is not conclusive, and it is not an accurate report. Coming to another case example. Here is a 53-year-old lady, postmenopausal, presented with abdominal pain and bloating, and she has history of previous hysterectomy. She underwent an ultrasound examination, and the report states that the uterus is absent, hysterectomy noted, normal left ovary, the right ovary contains a complex mass, no free fluid in the pelvis. The conclusion is that complex mass in the right ovary suggests referral to the Gynecology Rapid Access Clinic. Just spend few seconds to look into the report, because we're going to analyze it. Does it fulfill the basic guidelines? Is it a conclusive, accurate report or not? Okay. What do you think about this report? Let's take the positive points first. Okay. It is a concise report. Again, no ambiguous terminology, no inappropriate technical language. There isn't any irrelevant information. Now, did she or he state any limitations in the report? No. Does it address the clinical question? Well, to some extent. It has mentioned that there is an adnexal mass, but at the end it's left to me because there's no description of the mass, how big it is, what's the nature of the mass, and Dr. Divya has nicely explained to you that if you notice any adnexal mass or cyst, then it has to be described. Is it echogenic? It is echoic? It is hyper? It is what's the size? Are there any papillary projections? All these things have to be described. No abbreviations used. So I don't, it's again, I think everyone will agree with me, it's not a conclusive or an accurate report. Again, no measurements of any of the individual structures, and again, the sonologist did not give us the possible diagnosis or even the differential diagnosis. And not only that, no, but the good thing about it, actually, if I just go back to it, the good thing about it that it gives an offer to the next step, what to be done. So there's some sensible suggestion here, is that the patient has to be referred to the Gynecology Rapid Access Clinic. So this is one positive thing in this report, that she has recommended what is next to be done. Okay. But overall, it did not fulfill the full criteria of the full checklist of an ideal Gyne report, and we don't consider it fully conclusive or accurate. For the same case, with the same presentation, there's another report here written in this way. For the same case presentation of the postmenopausal lady who presented with abdominal pain and bloating. Her report this time is written in this way. Transvaginal ultrasound performed with verbal consent. Good views obtained. Uterus is absent. Hysterectomy noted. Sorry. Okay, the uterus is absent, hysterectomy noted, the left ovary is visible, measuring 10 by 15 by 18 millimeter, is mobile and appears quiescent, compatible with age and postmenopausal status. The right ovary contains a smooth multilocular mass of 5 locules, measuring 100 by 98 by 125 millimeter, with anechoic content. No crescent sign visible. The lesion is mobile and non-tender. Iota color score 1. No free fluid is seen within the pelvis. And the report is concluded with smooth and avascular multilocular mass, 5 locules, in the right ovary, suggests referral to the Gynecology Rapid Access Clinic. So have a look at this report. What do you think of it? Is it a thorough report? Is it conclusive? Is it accurate? Does it fulfill the basic guidelines that we have gone through earlier? Does it really answer the clinical question with which the patient has presented? Yes I think everyone will agree with me. It's a concise, and it's written in a very concise style, no ambiguous terminology, no inappropriate technical language, no irrelevant information used, limitations have been stated. It really addresses the clinical question. It gives me an idea, what do I deal with? Abbreviations used carefully, and it's really conclusive and accurate report. Okay, here is the end of my presentation, and I think by now it's clear to everyone why it is so important to spend a little bit of time at the end of your ultrasound examination to write down a good and a concise Gyne report. Thank you for listening. Thank you so much.
Thank you, Dr. Saada, for comprehensive presentation. And now we will go to informed consent imaging recording report writing in obstetric. Done by Dr. Ahlam Al-Kalbani. Graduated from Sultan Qaboos University in 2005. She did her master in from Ireland School of Ultrasound in 2011. She is specialist in OB/GYN at Royal Hospital and unit in Royal Hospital. Welcome.
Thank you, Dr. Fatma. Thank you for the introduction and welcome everyone. I will just share my screen.
Wait, I should stop sharing.
Saada, please stop sharing.
Yeah, I'm looking for the icon. You share, no, stop video. It has disappeared.
At the bottom usually.
Yeah, stop sharing. I'm not getting Zoom share. No.
I think Hadi, this is my picture. Saada, khalas. I think I stopped sharing. I stopped sharing your screen. Okay, so welcome everyone. This will be the last lecture for the day and the last lecture for the course. It's actually just a repetition and a recap of whatever was said earlier, and I'll be whisking you back to obstetric now, and my lecture will be informed consent, image recording, and report writing in obstetrics. Lots of the information was already talked about by Saada, so I'll go through whatever is new information or just go through or repeat whatever Saada has said. So the way you communicate what you have seen is just as important as the way you image. The way you word your reports to the patient and the clinician is important because the report is the basis of decision-making and patient management going forward. So at the end of this session, hopefully you will know when to obtain informed consent for an ultrasound examination and how to do it. You will be able to record images of ultrasound scans and know how to store them digitally, and a brief note on the way you describe the ultrasound findings of an obstetric scan. Those will be addressed with the key questions. When do you ask for an informed consent? And what are at least 3 things you need to include in your obstetric ultrasound scan report? And should ultrasound reports, ultrasound images, should they be stored? How to do it and where to do it? So before we examine any patient, we need to obtain an informed consent. And the consent process is a continuum beginning with the referring healthcare professional who referred the patient to you and requested the ultrasound, and ending with the healthcare professional who carries it out. And you have to understand that it's the patient's right to determine what happens to their body. And this right must always be respected. In fact, respecting the autonomy of individual pregnant women may be a legal necessity and a professional responsibility. So it is essential, like I said, to obtain an informed consent before performing a scan. So when the patient walks into the ultrasound clinic, you double check the patient's name and ID to ensure it is the same patient that has been referred to you. And before you start, you explain what you are going to do. So the patient is going to undergo an ultrasound scan, which would be predominantly done with the transabdominal route.
Ahlam, your voice is disconnected. So can you check your microphone?
Can you hear me now?
Yes.
Okay. Shall I repeat the slide then?
Please, yes.
Okay, fine, sorry. So like I said, it's essential to obtain an informed consent before performing a scan. And when the patient walks into an ultrasound clinic, you have to double check the patient's name and ID to ensure it's the same patient that has been referred to you. Before you start your examination, you explain to the patient what you're going to do. So the patient is going to undergo an ultrasound scan, which will be predominantly done abdominally. It may be necessary to do it transvaginally as well. You will be looking at the fetus organs and growth. And at the end of the scan, you will explain what you have seen and you will put a plan of action going forward with the pregnancy. The fact that the patient agrees to this and then gets onto the couch, this is an implied consent that they are going forward for the scan. So in our setup, an oral consent is accepted. And I'm talking about an ultrasound. If you are going for an invasive procedure, then that's a different story altogether. Okay. So this was explained by Dr. Saada already, the image, the examination. So the ultrasound assessment is not just the time that you scan the patient, it starts before that. So before the examination, you want to answer the clinical question. What is the indication of your scan? Are we dating the pregnancy? Are we performing an anatomical survey? Or are we evaluating growth? And during the examination, what are your specific observations? What measurements are you going to take? And what images are required to answer your clinical question? And after the examination, of course, what is your conclusion? Description of findings that you have seen should be part of your report. And if you can distinguish normal from abnormal. And finally, is it possible to arrive at a diagnosis or at least a differential diagnosis? So what each image should include? We need to know which each image that we provide or each image we store must contain. So the image must first contain the patient's name, of course, and other identifying information like the patient's ID, the facility identifying information, the name of the hospital or the clinic, the date of the ultrasound examination, and this is very important. The image orientation, like everyone explained, the dot to be on the left side of the screen, the details of the ultrasound machine settings, and this is provided automatically by the machine, like the frequency, the power, and the scale, the label of image structure if it is not obvious. If there are structures that are difficult to interpret, you need to label them to make it easier to go back later and compare your images. Ideally, all findings should be recorded either digitally or in a paper in patient's file. They should, as minimum, include all measurements and abnormal findings. Hard copies of all images should also be stored either as a printout or photocopies or videos or electronically in the machine. A report should go in the patient's chart and another report should go to the provider, and the sonographer
Ahlam, your voice again disconnected.
I'm so sorry. Okay, so your image storage, your report and image storage, you should have a copy at your facility. Report should go in the patient's chart and to the provider who referred the patient to you, and you should keep a report at your facility. Of course, this again depends on the health care system in your country and how the setup is. So why do we need to have a report? Like Saada has mentioned earlier, it is a medical legal document. It is the primary mean of communication between the sonologist, referring clinician, and the patient. It constitutes your clinical opinion of the interpretation of whatever you have seen. It answers the original question and provides information and gives information on how the patient management. So for that, it should be accurate, clear, concise, and logical. The basic guidelines already, Dr. Saada has gone through it, so I will not go through it, except you should be aware that you as a sonologist are fully responsible for the accuracy and content of your report. And you should write your report as soon as possible after the examination is completed, not towards the end of your clinic. And you should also be aware of your limitations and seek advice whenever necessary. This also has was already spoke about by Saada, so I will not go through it. In summary, the report should contain the clinical history, the structure examined, descriptions of your findings, interpretation of your findings, and a conclusion or a differential diagnosis. Okay, so like we said, your report should include standardized terminology that is used or understood everywhere. And just a brief note on that. There are specific terminologies that we must use. For instance, we report the ultrasound image that are completely black as anechoic, like follicular fluid. Those that are almost black with some whitish areas as hypoechoic, like the amniotic fluid. Areas which appear very white and bright on scanners as hyperechoic. And when the appearance of the organ appears very bright, it means the mass is more solid. So the more solid, the more bright it is on the scan. And whenever you see a solid mass and heterogeneous, pattern, that's a mixture of and hyperechoic. It can also have a mixed echogenic mass, but it's consistent throughout, and this is called a homogeneous mixed echogenic mass. So these are images to clarify. So in this upper left image, this image is of a cyst and is completely black. So we report this as an anechoic cystic structure. For this image in the middle, this is a lighter volume, and you can see there is some haziness. This is a hypoechoic structure to report. For this image here, you can see this is a bowel, which appears to be very bright in some areas compared to others, and we report this as hyperechoic. And for this image over here, this is a homogeneous with mixed echogenicity, and this final image here, you can see this is a heterogeneous with septation, and you see this echogenic fine lines here, and this is a heterogeneous mixed echogenicity. Other things we describe is the shape, round, irregular, and the contour, the contents, if you see any septation, any papillary projections, acoustic shadowing that Dr. Divya has gone through, posterior acoustic shadowing or acoustic enhancement, and the demarcation relative to other organs, whether there is capsule, whether the whatever you're assessing is adherent or mobile. So if you see this image here, there's with the papillary projections, and this is an image of a bone, and you see this acoustic shadowing posterior to the bone. So what the report should include: the date, patient's name and medical number, the route, like Saada has mentioned, transvaginal, transabdominal, or both, whether or not you had a chaperone, any abnormal findings, the response to clinical question based on the above findings, your comment, recommendation, and most important, your signature. So in an ultrasound setup, an obstetric setup, what are the main indications to do an ultrasound examination? There are lots of indications, and most important of which, of course, confirming the pregnancy, confirming the viability, confirming the gestational age, multiple pregnancy, and assessing fetal anomalies. If it's an early pregnancy, the indications also include measuring the nuchal translucency and cervical length. So in summary, let's say, rather than in detail, your obstetric report should include the approach, transabdominal, transvaginal, or transperineal, the viability of the fetus using M mode, checking the heart rate and the rhythm, an intrauterine pregnancy, the location, single or multiple, and if it's multiple pregnancy, what order of multiplicity, and the chronionicity and amnionicity. And of course, the placental localization. Other information should be included in the report: specific ultrasound requested, the name of the healthcare provider and contact information, relevant clinical information, comparison with prior studies, especially if you're doing a growth scan or you're comparing the fetal growth, and urgent report and findings. If, for example, you see a fetus with high Doppler, you should call the relevant party and report who did you call and who did you inform and what action will be taken later. So now I'll go through each let's say, each trimester or each part of the pregnancy and what the report should include. We'll start with the early pregnancy. So in early pregnancy, your report should include, in addition to whatever we said earlier, your name and everything, you should include the confirmation of the intrauterine location of the pregnancy, the presence of heart pulsation, if it's a single or twin, and if it's a twin, the number and chorionicity. If you're doing a dating scan, you need to again confirm of fetal heart activity, the fetal biometry like crown rump length, ultrasound assigned gestational age, and ultrasound assigned expected date of delivery, whether you are going to use the CRL or the LMP. Now, if you're doing an anatomy scan, or you need to assign again the gestational age as calculated from your previous ultrasound dating, confirmation of fetal heart activity, placental site in relation to the internal os, amniotic fluid volume, the fetal biometry that includes head circumference, biparietal diameter, transcerebellar diameter, posterior horn of the lateral ventricle, abdominal circumference, and fetal femoral length. Anatomical survey describing any abnormal findings, and you can do that like Dr. Saada has shown you. You can have it. You can have a standard list that you can go through, and then finally your comments and recommendation. And these includes the 6 steps approach that we have spoken.
Again, your voice disconnected.
It's fine, Doctora. So if you are doing a growth scan, again, gestational age as calculated from your previous scans, confirmation of fetal heart activity, fetal position, placental size again, amniotic fluid volume, and your fetal biometry, including the head circumference, BPD, abdominal circumference, femoral length, and your estimated fetal weight. If it's a twin you're assessing, then chorionicity again should be documented, and the concordance of the fetal growths. This is a case example of a growth scan. We'll start, like I said earlier. This is the operator who did the scan, the name of the sonologist, the ultrasound system. what route we are using, transvaginal scan. The gestational age was at 7 weeks. And then the assessment of early pregnancy, you can see that it was listed that it is an intrauterine cavity with a regular outline. The yolk sac was seen, the embryo was visualized, and the heartbeat was visualized as well, with the fetal heart rate documented. And the CRL is corresponding to the gestational age. And there is the conclusion put forth that ultrasound-based diagnosis is a viable intrauterine pregnancy. Moving forward with the same patient, we're using we're assigning her pregnancy, dating her pregnancy according to her LMP. Now we're doing her growth scan. This is her obstetric history. And this is the plotting of her parameters, the fetal parameters by parietal head circumference, abdominal circumference, and femur length. The red dot here is that on the day you're assessing, and you can see here that the abdominal circumference is falling below the 5th centile. Then moving on to doing the Doppler ultrasound, umbilical artery pulsatility index, middle cerebral artery pulsatility index, and cerebroplacental ratio are all within normal. Then it gives you a conclusion of what happens with the pregnancy. The labor was induced, and the outcome was the birth weight of a fetus, male baby of 2.4 kilograms, and seems okay. So if you want to go back and read more about the anatomical survey, you can find it in the ISUOG website, a clear guideline of the routine anatomical mid-trimester fetal ultrasound scan. So the American Institute of Ultrasound of Medicine recommends very clearly that there should be a permanent record of the ultrasound examination and its interpretation. Images of all relevant areas, both normal and abnormal, should be recorded in a retrievable format. Retention of the ultrasound images and reports should be consistent both with clinical needs and with relevant legal and local healthcare facility requirements. So I hope we covered the key points. Together, I'll include myself and Saada. Informed consent should always be obtained before performing any ultrasound examination. Any abnormalities detected during a scan should be documented using digital media or photos in the patient's file. A thorough report should describe the result of an ultrasound scan, and the report's conclusion should indicate any action to be taken by the clinician as follow-up to the scan. Thank you. That's all regarding my presentation.
Thank you, Ahlam, for the informative presentation, and thanks to all the speakers. Actually, today all of them on time, and I think we finish even in area. So it is a good opportunity for all of you if you would like to ask any questions, whether related to today's session or even the previous sessions. So the floor now is for the candidates if they would like to ask questions. I think we went through most of the question. Myself, I have answered all the question which is related to the cervical assessments. So maybe Dr. Mariam, if you would like to answer some of the questions, let me just go through them. This is a question actually to Dr. Divya. In scoring of vascularity in relation to ovarian lesion, is it ideal to use color flow Doppler or power Doppler?
Thank you for the question. Yes, it's a good question. It's actually better to use power Doppler because power Doppler is more sensitive than color Doppler in picking up slow flow. So if your machine has it, use power Doppler because it's more sensitive.
Thank you. And there is another question which is to Dr. Dina. Is it, what is this, required to document fetal heart rate in early pregnancy?
Well, we can use a mode in the first trimester. Yes, we have to document it. Yeah.
Okay.
But with a mode, don't use color or power Doppler, pulse Doppler, I mean. Use the M mode only.
Okay. And there
Sorry,
is
may
another.
I ask Dr. Moza, may I ask a question to Dr. Dina? Do we actually have to mention or report the rate, the heart rate, or is just present or absent in first trimester?
Yes. Yeah.
Rate.
Yeah, we can. Yes. We can just apply the M mode and then we can calculate the fetal heart rate. Yes. We can do that.
Actually, if I may intervene,
the-
early pregnancy, it is not a must to have the fetal heart rate. Like if you're scanning at 6 to 8 weeks, it's enough if you just mention fetal cardiac activity is present or not. Heart rate has a role during the 11 to 14 weeks scan because that is when we look for tricuspid.
Screening. Yes.
Even if
Trisomy
you mention
screening.
present or absent, that is enough if you're assessing early pregnancy.
Yeah, above 11 weeks, you can do it and then we can record it. This is what exactly the meaning.
Even if you don't use M mode and just document whether it's present or absent.
You know that.
Okay, there's another question. In a hospital which is too far from fetal medicine unit, it is not easy to refer every pregnant woman according to guideline. Are there any intermediate guideline for referral? I don't know if Divya would like to answer this question because I couldn't understand what did she mean. Anyone?
Personally, if you're not able to understand something and you feel that something is out of ordinary, it's always better to refer because you don't want to end up making a mistake. But if you feel that you will end up making a lot of referrals, then actually a good practice is to follow up whatever you refer so that you understand whether what kind of referral you are doing. So it's something that you learn with experience, and it's very difficult.
Also,
I think
if sorry,
guidelines
Doctor, continue.
only be based on when you make guidelines, you have to see a lot of things like what is the training level of the person who's scanning, and I mean, a lot of factors. The local factors have to be taken into consideration. So it's not possible for a society to come up with guidelines, to suit everyone. So that is something that you have to build up on a local level regarding referral.
May I comment on that? Because at the end of the fibroid talk, there was a section where we talk about referrals. I think it is important to refer if the referral will make a difference to the patient management, which is very important. I think that's the main question, whether is this referral will, if you don't refer, is there is a harm? If you refer, is there is a benefit to the patient? Because it's very important. I think whether it is obstetric or gynecology, the question is of the benefit. And if there is a benefit, which is, there is quite a bit of benefit in most of the time, then it is better to refer. And then as Dr. Divya mentioned, we all learn by referral and discussions, and the follow-up on those things would be very, very important.
Thank you, Mariam. There's another question about the viability scan and whether we need to comment on the integrity of the skull in the viability scan. It depends. I mean, if you do a scan, viability scan at 12 to 14 weeks, which is happening in most of our local health centers, you should be able to comment on the integrity of the skull because from 11 weeks onward, the skull bone can be visualized and skull bone already calcified, and you can nicely trace the skull bones. So if you are not able to see the skull bone or there is a defect in the skull bone, then of course you have to comment on this. And you have to refer the patient for early anomaly scan because in previous lecture it is already have been shown that early anomaly scan can be done from 12 weeks. especially if you have skilled person who can do or skilled operator who can do early anomaly scan at 12 weeks. Major structural anomaly like anencephaly, omphalocele, obstructed lower urinary tract with megacystis, limb body stock anomaly, all these can be identified, which is lethal malformation, can be identified at 12 weeks, which is, if you would say, it is a viability scan time in most of our local health centers. So yes, you should comment on the skull integrity if you are able to comment. I think.
Yeah, part assessment.
I think there was a question to Dr. Divya about demonstrating sliding sign on endometriosis. I think it will be very beneficial also to our residents who are attending. It would be great if Dr. Vidya have a short video or something.
Yeah, I think that is in the answered question. Maybe I missed it. Yes, Dr. Vidya.
I have the video if it is
yes,
okay.
Of course, you can demonstrate that. I mean, we have enough time to show that.
Right now. Host has disabled screen sharing. That's what it says here.
Oh, sorry. No, I stopped my share screen.
It says host disabled participants. So I think the host would have to allow me to.
Zakia, are you around?
Yes, Doctora, it's now allowed.
Okay.
Thank you.
I'll answer two questions. I think there was one question on the appearance of abnormal fallopian tube, or I think dilated fallopian tube. So first, because that's more simple to answer, so I'll just answer that first. So obviously, when the fallopian tube is abnormal, you will see a normal ovary or an ovary at least separately. So that would be the first clue that the structure that you're seeing in the adnexa could be the tube, because you'll be able to see the ovary separately. And an abnormal fallopian tube can be a hydrosalpinx or a pyosalpinx. So fallopian tube, because it's a tubular structure, so when it's abnormal, it again forms a linear tubular structure as you see in these images. So these are all dilated abnormal fallopian tubes, and rather than the oval or round appearance which an ovarian cyst has, these lesions tend to be linear tubular in shape. And you see incomplete septations, as you can see in these images. These are the incomplete septations, which are again very typical of hydrosalpinx. In pyosalpinx, the mucosal folds get thickened and you get this characteristic cogwheel appearance in pyosalpinges. Whereas in hydrosalpinx, the mucosal folds are thinned out, so you get this characteristic beads on a string appearance when you see this tube in the transverse section. So this is a longitudinal section and this is a transverse section. So I hope by looking at these pictures, you can now understand what an abnormal fallopian tube looks like what a hydrosalpinx and what a pyosalpinx looks like. If it is a hematosalpinx, there will be ground glass appearance. Rather than this anechoic appearance, there will be a ground glass appearance here, because as you know, blood products, just like endometrioma, hematosalpinx also tends to have a low level internal echos, ground glass and internal echos. So that is about the fallopian tube. And now I'll demonstrate the sliding sign. What is interesting about sliding sign is that positive sliding sign, that is presence of sliding sign, is a normal finding. So I would encourage you that you should, in every patient, even if she doesn't have any abnormality, and especially if she doesn't have any abnormality, you should try to elicit the positive sliding sign, because that's a normal finding which you will see in every case. In fact, there are studies which have shown that if you are training yourself in sliding sign, after doing around 40 to 50 normal cases, then you know what a positive sliding sign is. So you need to see 40 normal patients before you are confident on seeing a positive sliding sign. So this is what a sliding sign looks like, as the name suggests. You just have to look for the sliding of the bowel loops. You just have to see how the bowel loops glide freely along the posterior aspect of the cervix, as you see here, the posterior aspect of the uterus, as well as in the region of the fundus. The uterus is surrounded by bowel loops here, and you can see quite well in this video how the bowel loops are gliding freely past the uterine cervix, uterine body, and in the region of the fundus. So this is what a normal positive sliding sign looks like. Now, when will the sliding sign be negative? When things are fixed. So when there are pelvic adhesions, for instance, in case of endometriosis, this is actually a case of deep infiltrating endometriosis. And you can appreciate now how you will not be able to see the free gliding of the bowel loops. Now the bowel loops will be present here, here, and you will see that they will not be gliding freely, though I'll be pushing the uterus with the transducer. Now see, you cannot see the way you were seeing in that video, any bowel loops sliding past the uterus. Just keep looking and you'll be able to appreciate that the way those echogenic bowel loops were, gliding freely along the posterior wall of the cervix, that's not seen, because here actually, which I'm not showing you now, but here was a lesion of deep infiltrating endometriosis, this hypoechoic thing. So as a result, the bowel is fixed to the cervix and to the posterior aspect of the uterus. It's not gliding freely. And you can also appreciate the structure. This is the ovary. First, the ovary should be in the adnexate. The ovary has come here right behind the uterus. It is because there are adhesions. So as a result, the ovaries move medially and they get stuck to the posterior wall of the uterus in endometriosis. And though I'm pushing so hard, but it's not hard actually, but normally this ovary, if it was free, it should have glided freely against the posterior wall of the uterus. It's not. It is just stuck to the posterior wall of the uterus. So this is what a negative sliding sign looks like. You don't see the bowel gliding freely along the posterior aspect of the cervix, the uterine body, and in the region of the fundus, depending on where the adhesions are. If adhesions are in the cervix, then it will not glide in the cervix region. If they are higher up, then you might see some gliding in the cervix region, but you may not see in the fundus and the posterior uterine body. So I hope now you've been able to see what a negative sliding sign, which is abnormal and suggestive of adhesions, looks like. Thank you.
Thank you, Dr. Vidya. Thanks. There is another question actually for you about the claw sign.
The claw sign?
Yes.
Oh, somebody has.
Please explain claw sign also.
Now, I don't have the images as of now, but claw sign is also similar to the crescent sign. So whenever you have to see whether the lesion is ovarian in origin or not, if you cannot see the ovary at all, then you can make a conclusion that since ovary is not seen and you see an adnexal mass, then probably that mass is coming from the ovary, because ovary is not seen at all. But sometimes what happens is that there is some amount of ovarian tissue which is stuck at the periphery of the lesion. It's around the periphery of the lesion, and you will identify its ovarian tissue because you will see small anechoic follicles within it. So if you can see with my hand, if it's just a thin amount of, imagine this is a thin amount of ovarian tissue, and this is the lesion here. So it will form if you see here, it will form a crescent. And if you just look like this, it will also form a claw. So crescent sign, claw sign, they all mean the same thing. This is the claw or the crescent, which is being formed by the normal ovary, and the lesion is here. So this presence of this sign, it helps you understand that the lesion is arising from the ovary, that is, it is ovarian in origin, because the normal ovarian tissue is gripping it like a claw.
Thank you, Dr. Divya. There are few questions which are related to the cervix. One of the questions which already I answered actually about the routine cervical assessment in all pregnant patients, whether it is recommended or not. So actually the study which have been done and which have been published, they demonstrated that routine cervical assessment is not recommended in all pregnant patients because it is not cost effective. So what they have found that if you want to prevent one preterm labor before 32 weeks, then you have to scan more than 1,500 women, which is not cost effective. So cervical assessment or cervical screening is effective in high risk patients who have prior risk for preterm labor. And there is another question about the cut line or for the cervical length. So in low risk patient, for example, a patient who is primary, and you did cervical length measurement because transabdominally while you are doing routine anomaly scan, you saw that the cervix is short and you confirmed it by transvaginal scan and you found it is a short cervix. In a primary patient, in low risk patient, some study, they put the cut line 15 millimeter in low risk patient, but in high risk patient, 25 millimeter. For example, a patient who's prior 1 mid-trimester or 2 mid-trimester or early preterm labor, then the cervical length cut for when you do cervical assessment in the mid trimester 16 to 24 is 25 millimeter. I hope it is clear and different understanding of what I mean by low risk and high risk. Regarding the funneling,
sorry, can I be greedy and ask a question?
Yes.
Regarding cervical assessment, something very commonly that I see, especially patients who are treated for infertility. Like, for example, typically a primary IVF pregnancy for whatever male factor, female factor infertility, but they are treated with lots of things to prevent miscarriage. Is 25 centimeter, do we treat them as high risk pregnancy based on that? They don't have a specific obstetric fact history related, but especially in Oman, they paid quite a bit of money with IVF, and I don't know if doing a cervical circlage in such a case is warranted.
Yeah, actually, we all having the same issue. The issue that Dr. Mariam, what is happening, that this patient has been referred from fertility treating doctors who already convinced the patient that continue on cyclogist, dofaston, progestogen injection is very important for you to have a surviving baby at the end of the journey. So if she comes to you and you are trying to convince her that, no, dear, we did cervical, for example, assessment at 12 weeks or 16 weeks or 20 weeks, and your cervical length show normal cervical length for your, and there is no prior history that put you at the group of high risk for preterm labor, still the patient, she will believe on her fertility doctor because already he gave her a live fetus. So majority of them, they will prefer to continue what the treating doctor have told her. And from the ethical point of view, it is difficult also to say that my colleague, the fertility colleague, actually is wrong. Yes, you will tell her that we understand and we respect your fertility doctor advice, but the current recommendation is this and this. It is up to you whether you want to continue the same the treatment or the management plan, or you would like to follow my advice. So it is leave it up to the patient, because it is precious pregnancy for them. And we have actually seen patients who, once they discontinued dofaston by any means, she had a bleeding and she is coming blaming you. You see, you told me to stop dofaston, I stopped dofaston, and now I have bleeding. Although the bleeding is not actually related to the dofaston, but they should start raising complaint against you, and they may lose the trust in your management or in your advice. So that is actually what I'm doing with such patient. I understand it is a precious pregnancy, and I usually respect their wish. And I try to guide them, but it is up to them whether they want to follow my advice or to follow my fertility, the fertility college in their management.
Thank you.
The other question is about the dynamic cervix. Didi, I already answered this question. Do you have any comment about dynamic cervix? When we do a cervical assessment, we sometimes describe the cervix as dynamic cervix. So
yes,
if you
I agree with whatever you described, Dr. Musa, that at times when we are seeing the cervix, initially it might just appear to be normal, and then suddenly you will see the internal os opening and there would be funneling. And then after, you would get like a very short, cervix would get shortened if you measure at that point of time. And then again, after a while, if you see again, that funneling would close, and that is what we call a dynamic cervix. And that is why it is recommended that actually you should keep looking at the cervix for 5 minutes before you say whether it is normal or not. So that you look for this dynamic cervix entity. So it's recommended to look at the cervix for at least 5 minutes.
Yeah. That is what is actually I meant also from the importance of having like 3 minutes instead of just putting the probe and then taking the probe without checking the cervix properly. There is a question about the BMI, body mass index, and obese patients, and whether it is recommended to refer all such patients because of such limitation to the fetal medicine unit. They will kill me now if I will comment on this. So give you a comment on this.
See, high BMI is a big problem. In my clinic, at least since I'm in a city, almost 60s to 70% patients are high BMI. And if we start referring to a cardiologist for fetal echo, then it's, it's just not possible. So you have to learn how to work around high BMI. Obviously, if you cannot see at all, then you have to mention that you could not take images to confidently say that the heart is normal, and that would justify referral. But just because she's high BMI doesn't allow you to not do the proper assessment. You just have to work around it. For instance, I'll give you some tips like how do you scan for high BMI. In high BMI, there are certain areas through which if you put your probe, you will be able to see structures. The areas are, for instance, if she has a big pannus, like a lot of fat in the front of the abdomen, if you go in the suprapubic area under the pannus, you ask her to lift the pannus and go in the suprapubic area, you get an acoustic window there. Then you can get an acoustic window around the umbilicus. So if the baby is too low, just ask her to fill the bladder so that the baby comes up around the umbilicus area and then scan from there. If that doesn't work, then you sometimes have window from the iliac fossa, that is from the sides in the lower abdomen. So then you either look from there or make the lady turn and try to look from those sides. So these are tricks that you have to learn. And also I also adjust the machine settings when I work with high BMI. You will have to go and look at your knobs. There is a knob known as frequency. So normally when you're doing fetal echo settings, this frequency knob normally is by convention set at resolution. And resolution means it's a high frequency, because you know that if you remember your biology and physics, you need high frequency for high resolution. And so in cardiac, when you want high resolution, you use high frequency. But when it comes to these high BMI patients, you should actually reduce the frequency from high, you should take it to medium or low, because then it will have more penetration. And this really helps. If you will just try it once, you will see it makes a lot of difference. And another thing which you can do is obviously keep your the width of the box as narrow as possible, because that will also improve your resolution. And another thing, rather than using this black and white, go for colors like sepia or cool blue, because they give you more contrast to the eyes. Only for cardiac. This is only for cardiac. Don't use it in brain or any other structure, because there you will miss. Only for cardiac, you can change the color from the routine gray color that we have to sepia or to cool blue. And that also gives you better delineation. So
thank you, Lydia. Thanks.
I think also, Dr. Moses, the machine, maybe the people who are having low-end machines, I mean, basic machines, they cannot do good scanning on for the high BMI. So at least better machine, mid or high-end machine would be better. So if they have very basic machine to do the heart examination, in this case, I think they can refer that patient. I mean, for answering such a question.
Yeah, that's why it is important actually when you refer a patient to document your the limitation. For example, you don't have proper ultrasound machine, but most of the polyclinics, especially polyclinics, they have good scanning machines, and they have also operators who are already trained. So the limitation with obesity, as Divya said, it is with everybody, with everyone, even trained operators. But what you need to do is to learn the technique that help you to overcome such limitations, and help you. And even if you cannot, for example, visualize the heart, because what is happening when you do early anomaly scan at 12, 16 weeks in obese patient, may give you that good, transvaginal approach, may give you that good approach of visualizing certain organs, but you need to repeat the echo at least at 18, 20 weeks for such patient. No need to go through all the things, but at least the echo before, advancing 24, 26, when it is difficult, with taking abdomen, and so that is one of the things that you have to do it. There is another question about for Livia about ovarian ectopic pregnancy. What the question was, any special appearance for ovarian ectopic pregnancy?
Though I didn't give the lecture on ectopic pregnancy, but I'm sure whoever gave you that lecture must have told you that ectopic pregnancy has a very typical bright echogenic rim of chorionic tissue around it. So when you see an ectopic pregnancy in the ovary, first you will have a history, like history of an assisted reproduction technology or something which would kind of point that there is a high risk of this patient having an ovarian pregnancy. And then the ovarian pregnancy typically has a very thick, bright, echogenic rim of chorionic tissue around it, which helps in differentiating it from a corpus luteum in the ovary. So you will have to look at the images of ovarian ectopics and then you will understand what I'm saying. And if you switch on color, then this echogenic tissue can also light up with color. But color Doppler is not that reliable. You have to look at this 2D appearance of a bright, echogenic, thick rim of tissue around the ovarian ectopic, because it'll be like a gestational sac and then surrounded by this echogenic tissue, or it might just be a blob of echogenic tissue. It'll be brighter than the ovarian stroma. So that is what an ovarian ectopic looks like.
Thank you, Divya. There is also a question about the importance of cervical assessment in multiple pregnancy. There is different, views regarding the cervical assessment, routine cervical assessment in multiple pregnancy. Some guidelines they recommend, the other guidelines they don't recommend, because studies have shown that even if you do cervical assessment and find short cervix, what is the next step? Do you put cervical circulaire? Do you put her on progestogen supplement? Do you offer her cervical pessary? Because still the study didn't show, the good outcome with each intervention. So it depends also on her prior risk. If she's, for example, had previous history of preterm and she's now pregnant with multiple pregnancy, and you see cervical short cervix, then yes, you go ahead and put cerclage or put her on progestogen. But if she doesn't have any, prior history, even if you do cervical assessment, what is the next step? Yeah. So, and Divya, do you have any comment regarding this?
I agree, Dr. Musa. I agree with whatever you're saying.
Yeah.
There are guidelines to suggest, there's no intervention in.
Yeah, it is difficult actually. Yeah.
Yes.
And then there's a question about whether those patients who already have cervical circular, do you recommend routine, serial cervical assessment after putting a stitch? So it is not recommended. That's what I understood from all the studies have been published. But myself, I'm doing it. I have seen cases where cervical circulage has been put, and then the patient is coming with reduction in the cervical length and with coning, and so such patient, I prefer to do cervical assessment and then put them maybe on progestogen. Maybe it can help. I have seen cases where progestogen actually help, and other cases where which I don't like it. I don't like cervical circulage. It's very invasive for me. But I had few cases where I took them again for recirculage, and it was working. It depends on your management, and on your you have to look to the whole clinical scenario of the patient and then decide. Some patients, they already have they don't have living issue, and you are facing with that pregnancy, and you want to do everything in your hand just not to for the patient not to lose her pregnancy. But there's no like white and black. It's according to the clinical scenario. Question. I think we have answered all the questions. What is this? Women who do not deliver for at least 2 weeks after removing circulage, does it indicate that it is, what is? Does it indicate that in future pregnancy we shouldn't over circulage? That is a good question, actually. No, it doesn't indicate that we shouldn't put cervical circulage. It actually, you have to go back to the patient history and your clinical indication for putting that cerclage at that gestational age. If, for example, a patient, she didn't have prior preterm risk, and it is because it is IVF pregnancy, like Dr. Mariam, she said it is just IVF pregnancy, precious pregnancy, no prior history of preterm risk, no other cervical trauma or surgery or uterine anomalies, then there was no indication for you to put cervical stitch in that pregnancy. So in future pregnancy, that patient should be treated as low risk actually, and no need to put cerclage in the future pregnancy. But if the patient, she was already high risk, whether she had previous 2 preterm or 1 preterm, and you did cervical assessment and it was short cervix, then of course, putting a stitch in future pregnancy is recommended, whether she went into labor immediately after you remove the cervical stitch or after 2 weeks. I don't know others, any comment from other speakers.
May I ask, if we remove the cerclage and she stayed 2 weeks, not like she didn't go in labor, does that necessarily indicate there is no incompetence?
No.
That's my understanding. If that means she survived the critical time of pregnancy where the incompetence would definitely manifest. I am not sure if we have evidence that how soon after removing cerclage, how soon she goes in labor indicates whether there is any cervical incompetence or not. I'm not aware of any evidence for that.
Yeah, I agree with you, Mariam. This is why we say it is not actually give you an indication that cervical stitch was recommended when you did it or not. You have to look to the whole clinical scenario. It is not like an indication that it was not recommended. Any more question? I think we should end the sessions. If the candidate doesn't know more what it is, any role of, inshallah, everybody now interested. Any role of emergency cerclage? There is actually a role of emergency cerclage. We have residual cerclage, we have emergency cerclage, and all studies actually, it depends on your on the clinical scenario of the patient. Yeah, and we had cases where we put residual cerclage, and cases where we put emergency cerclage, and it depends on the patient clinical presentation. But yes, there is a role.
Dr. Moza, I don't know if any more questions, but may I comment on gynecologic ultrasound in high BMI women? Because I think I'm a gynecologist by nature, so people think it is difficult to scan only pregnant women during pregnancy with ultrasound. But actually, even in gynecology, of course, one of the things is that unmarried girls, we don't do transvaginal. So whatever struggle you have with the fetus, scanning a fetus in a pregnant woman, gynecologists have even more difficulty because you don't have that media of amniotic fluid and the baby swarming in it. All what you have is a full bladder, and then it is you and your luck. If she has a pannus, you go under the pannus. If it is not, you depress the umbilicus as much as you do, and all these things. Another thing that is an issue, I think those who are clinicians, a little bit less lucky compared in the bed equipment that they have, because pregnant women will lie down straight on the bed, whereas gynecologists, most of the time they perform transvaginal ultrasounds, and the bed is a clinical examination bed, not an ultrasound, specific ultrasound bed, which is like a wide, usual, like the admission bed, for example. So that narrow table, bending the legs and being in dorsal lithotomy for some time, it also needs extra space that the bed might not allow. Transvaginal probe has a certain length, which sometimes the soft tissue of the lady exceeds, and then you find your hand holding the probe, you are almost actually at the introitus instead of being outside the vagina. That's another challenge. Another thing is the soft tissue below the lady. that itself can be hindering your probe movement, especially if the probe is short compared to the length of the vagina. Sliding and rotating the probe and pressing down to get a better anterior view, and all those manipulations that you need to do is also will be hindered. So I think the high BMI, as you mentioned, it is a struggle across the board, whether both in pregnancy and also in gynecology. So even in transvaginal scan, it's not easy.
Yeah, thank you, Mariam.
Can I answer regarding the position, Dr. Mariam? It's always that we need to put the patient in a very good position. Like, although the bed on the clinic is straight, you can put a pillow or double pillows. It will put the butt of the patient higher so that you can introduce the transvaginal scan very nicely. And one of the tricks that we are doing, sometimes we can put the patient's butt at the end of the bed, and there is plenty of place. We can just push your bed to the wall, and then you can have a space at the end. You can put the butt of the patient by the end of the bed and put a chair there, and where her foot can be there, and then you can have a very nice space, especially if the patient is high BMI. It really sometimes even you cannot introduce the probe nicely into the patient, and with two thighs closing everything, this position would give a very nice space for that. So it's really sometimes challenging for a transvaginal scan if you don't have a place where you can move freely your probe. So I guess these are two tricks that you can use in the clinic.
Actually, what I was thinking, it's not only lifting up, although in obese patients, unlikely to get a proper scan if you're actually not putting. So the standard is that you are going to put something underneath. But what I'm talking about, sometimes the soft tissue itself is the one on your way. It's not the pillow that you are putting. So that would be coming forward, and your hand is actually on the soft tissue rather than on the pillow that you have put. Sometimes they are. The position tricks something that we learn with time, but definitely you cannot do without putting something underneath. But it's just challenging if the soft tissue is also protruding themselves, is becoming an extra pillow.
Thanks, Mariam and Dina. There is a question about risicocircular. Do we need to refer the patient to you? No need. Any senior obstetrician can do risicocircular, so please don't refer the patient to me. Okay.
You're getting extra business from this.
No need. Any senior obstetrician can do risicocircular. No need to refer the patients. I think we have covered all the questions.
Dr. Moza, can I ask a question about rescue circulage?
Yeah.
Is there an end limit of gestational age where you can do rescue circulage?
I mean,
you personally, as Dr. Moza, when would you not do as rescue circulage based on gestational age?
Up to 24 weeks, and I have a patient where we did rescue circulage at 26 weeks, but up to 24 weeks, yes. And I believe more in, I don't like circulage because it is really, recently I had a patient who had her cervix already fibrosed because of the multiple circulage that she had it in previous pregnancy. And we in the current pregnancy, we put a circulage at 12 weeks, and the cervix has multiple tears, and she had a buttonhole tear in the lateral and posterior lips, and we tried to put the circulage above these new tears, but she came, which I felt very bad. She came at 16 weeks with the whole cervical lip torn and prolapsed through the vaginal uterus. You see how traumatized it is. And because she had only 2 living issues, in Oman, she will continue to get pregnant, so she will come again within a year to me. So I took her again to the OT, and I involved my urogyne doctors because they are more, helpful in trying to retract and get enough length But she's 16 weeks, and we could, get enough length, and we put again another stitch. I hope she will continue the pregnancy. And I put her on antibiotic because, multiple invasive. I put her on antibiotic for 5 days, IV antibiotics for 5 days, just to avoid that also a risk of such invasive procedure, risk of ascending infection and chorioamnitis. So I hope she will continue pregnancy. So as I told you, and cervical sarcoidosis, I don't like it, but what to do then? If you don't have other option, then you have to do. And you have to involve your Gyne because they are much aware about how to retract the bladder, how to retract the bowel and everything. Are you doing, what is the question? Are you doing laparoscopic abdominal sarcoidosis? Yes. I had 2 cases where we put abdominal sarcoidosis because both Cervical and McDonald's had failed in previous pregnancy. So I requested our laparoscopy surgeon to put before she got pregnant, we put abdominal sarcoidosis laparoscopically, and when she got pregnant, she continued her pregnancy, and then we had to deliver her by cesarean section. But abdominal sarcoidosis, it has its own morbidity, especially if this patient, she ended in IVD or miscarriage or whatever, then you have to go back and move that stitch, which carry its own morbidity. So it's not unless the patient doesn't have any living issue, and then you are faced with such scenario, then yes, you can. But if the patient, she have at least one living issue, then no need to put the patient in another morbidity scenario. So that is about the preterm. Are you doing, this is we finished, what is this? Are you doing laparoscopic internal tightening? What is laparoscopic internal tightening? I don't know. Or the same, I think maybe the same question. Laparoscopic sarcoidosis. Can about the assessment test, I don't know what is she mean by the assessment test, whether it is cervical assessment. I mean, cervical assessment.
Post this workshop, the post workshop.
Okay, yes. That is a good question, actually. So we, prior to the workshop, we already emailed you the link for the pre-assessment. And what we expected from you that you already did the pre-assessment test. And now what we will do, we will send you the link for the post-course assessment test. And what we expecting from you is to go through the assessment test and answer the questions in order for you to get the certificate, whether certificate of attendance or certificate of competence based on your future plan. If you are planning to go for practical hand-on session, then you can do it either with the ISUOG, and that is depend on what you have filled during your registration time, or you wait when we will organize it locally and then we will advertise for it. So that is the future plan about the workshop practical hand-on and about the assessment test. So I think that is the end. Did I miss any questions? Yeah.
No.
So thanks for all those who stayed with us till now, and I hope that everybody enjoyed the workshop and it was informative and up to your what you expected from us. We will send you all the links of all the days, the recorded links. It will be emailed to you. I think Zakia, she did a great job. She already emailed the first and second day webinar to everybody. And she will email again yesterday and today's session to everybody. It is there on the YouTube. Even without sending you email, you can just search on YouTube about the ISUOG workshop in Oman, and all the record will come to you. So thank you again, and I would like to thank all the speakers for their great effort. Really, we enjoyed all the lectures today and last days. Many thanks to all of you, and I hope, inshallah, we'll meet again in another workshop next year. So thanks again.
Thank you, Dr. Musa.
Thank you.
Bye, everyone. Thank you.
Bye-bye.
Bye.
Thank you, Zakia, for your great efforts for
Thank you,
organizing
Zakia.
this
Definitely.
workshop. Always I forgot Zakia, but Zakia is in our
Behind
heart.
the screen. Behind the people behind the screen are forgotten usually.
Yes, yes.